hesitate to create chances and spaces to have these discussions. Last week, Prof. Osafo told me that there's a collaboration between Leicester, right? Leicester University and University of Ghana as a collaboration on research on suicide and mental health. And today, we're going to have some panel discussion based on work that in the space. As you can see, Center for Aging Studies and Psychology, I don't know if they are siblings or cousins or big brother, small brother, or father and son. But we, the two directors were just introduced as psychologists, particularly left psychology department to establish that. And anytime you hear about aging, in fact, today on my way here, I think I was listening to BBC, and there was some discussion about the importance of the psychology of aging. And I think I'm saying that within the context of psychology being relevant to so many things. And so we can't discuss suicide without discussing the psychology of suicide. I see a lot of faces from different backgrounds, but that tells you suicide is also multidisciplinary in nature. So I'm happy to have you all here. Welcome to Psychology, welcome to Center for Aging Studies, and please enjoy your time intellectually whilst you're here. Welcome, colleagues.
Thank you, Prof. Anum, for your welcome address. I would like to invite the Director for Center for Aging Studies, Professor Joseph Osafo, to give us a keynote address. Please, let's welcome Professor Osafo.
Thank you very much. I'm too tall. All right. Ladies and gentlemen, good morning. The subject for today, suicide, mental health, and criminal justice system in Africa, an interdisciplinary perspective, is a very important subject. The intersection of suicide, mental health, and the criminal justice system in Africa is a complex one, and that requires a certain disentangling approach and a certain interdisciplinary approach to address it. Currently, the overrepresentation of individuals with mental illness in the criminal justice system is a significant challenge facing criminal justice and mental health professionals and even policy makers across the continent. The issue is compounded also by high rate of suicide among those with mental illness, particularly in the criminal justice context. And some research is already beginning to show that the deinstitutionalization movement, changes in commitment laws, and stringent drug control regulations have all contributed to the rising involvement of individuals with mental illness in the criminal justice system. This phenomenon, often referred to as the criminalization of mental illness, has resulted in a disproportionate number of individuals with mental illness who are getting arrested, who are getting incarcerated for minor offenses instead of being diverted to mental health services. I remember meeting a guy who has been arrested more than 7 times because he keeps stealing a bunch of plantain. Well, later on we realized that he was suffering from kleptomania. And so you will keep arresting him. The interesting thing is that when you arrest him, he steals the plantain, he doesn't eat it, he doesn't sell it, he stays in his room until it gets rotten. So the lack of formal mental health training in police, lawyers, for police, lawyers, judges in many African countries hinders the proper management of mental health cases within the criminal justice system. And that, as a result, individuals with mental illness often face significant challenges navigating the legal processes and are more likely to be convicted and incarcerated. The prevalence of mental illness among incarcerated individuals in Africa has been documented. Consequently, with estimates that are ranging from 7% to 16% in jails. These are persons who have mental illness. The population faces an increased risk of suicide, with studies revealing that the suicide rate in prisons tends to be significantly higher than in the general population. This lack of sufficient mental health services and resources within the criminal justice system in Africa exacerbates this issue. And so many incarcerated individuals with mental illness do not receive necessary treatment and support, resulting in the deterioration of their mental health and consequently an increased risk of suicide. Additionally, the stressful and often traumatic nature of the criminal justice experience can trigger or worsen mental health issues, contributing to elevated rate of suicide within this group. And so addressing the complex challenges at the intersection of suicide, mental health, and the criminal justice system in Africa requires a collaborative and interdisciplinary approach. This involves integrating mental health services within the criminal justice system and fostering a strong partnership among mental health professionals, law enforcement, and the legal system. If we promote this by today's discourse from various perspectives, and we implement evidence-based interventions, then African countries can work toward decriminalizing mental illness, improving mental health outcomes, and reduce suicide rates among incarcerated individuals within mental illnesses. And so today, the panel that we have put together is going to be looking at this issue from various perspectives. Panel 1 will look at it, panel 2 look at it, panel 3. You will even hear talks on suicide and aging. We're also happy that we have found some of our friends and colleagues in the African region, sub-region, who want to, for example, contribute to the discourse. And so we'll be hearing them online, who will be joining us on this. And so on that note, I'd like you to just feel welcome, feel comfortable, and enjoy the various discourses that are going to be churned out here. We want to live here with a certain sense and understanding that the intersection of suicide, mental health, and the criminal justice system in Africa is a complex and a pressing issue, and that it necessitates a comprehensive and interdisciplinary response. So by tackling the criminalization of mental illness, enhancing access to mental health services within the criminal justice system, and fostering collaborative partnership, African countries and scholars can strive to reduce the disproportionate involvement of individuals with mental illness in this justice system, and also prevent needless and tragic loss of life due to suicide. I'm hoping that this multifaceted strategy and discussion today will be essential for promoting the well-being and rehabilitation of those who feel vulnerable because they have an illness that has been criminalized. On that note, you are welcome and enjoy the rest of the day.
Thank you, Director, for your beautiful keynote address. Colleagues, let me also say that we are being beamed live, all right? And so we would like, as much as possible, not to be crossing the cameras, because colleagues from other parts of the world are with us. Thank you so much. All right, so Prof, having given us your keynote address, as you said, we are going to have 3 different panel discussions here. The first will be on the theme Suicide in Africa, prevalence, risk, and public perception. The second, youth suicide and mental health in Africa. And then the third panel discussion, mental health and suicide among the older persons in Africa. Let me say that for all these panel discussions, there will be a Q&A. So if you have any question at all, you can just put it down. And when the time comes, you can just throw in your question. All right, so in order not to waste much time, let me call the panelists for the first panel discussion. Suicide in Africa, prevalence, risk, and public perception. We have in our midst Professor Kofi Boakye. Professor Kofi Boakye. Prof, kindly take your seat. Professor Emmanuel Niboye-Kwashi. Prof. Emmanuel Niboye-Kwashi. Is he here? All right, maybe he's on his way coming. We also have Professor Alain Timo Bila Lamo. I hope I have. All right, yes, I'm told that Dr. Alain Timo will be joining us online. All right. Okay. Yeah, so whilst waiting for Professor Kwashi, I think we can go ahead with, yeah. Well, I would just like to give you some 2 minutes, 3 minutes. Just tell us really what is that intersection we seek to explore. Suicide, criminal justice. Any intersection?
Okay, so thank you very much for having me here. I was hoping that I could project a slide to kind of talk through. So if that's an option, the acting guys can have my slide, and then maybe I can walk through that. But the motivation for this workshop, it's what has been captured by the HOD and also the director of the Center for Aging. The director of the Center of Aging I've worked with for many years, starting with my visit here as a Carnegie Fellow, and then becoming the lecturer here, and then going back to the UK to continue our collaboration. And so the motivation is this. We started a project in 2014 when I visited, and that was a funded project. It's probably the first project funded by the ORID in the department. And that was the starting of a conversation around an interdisciplinary approach to the issue of suicide, which Professor Osafo has led for so many years, starting with his PhD. So that's where it started. And that project was looking at suicide risks and the law. Me from an interdisciplinary background with particular interest in forensic psychology, it was pretty obvious to me that the problem of suicide cannot be studied from just one perspective. And so bringing us together enriches the conversation and also the intervention that we were hoping to build. So that has continued. It's been on and off with funding and no funding, and we are at the point where we are moving to the second stage. We are not just looking at Ghana, but it's kind of an African level projects that we're thinking about. And we think that we bring people from different perspectives to help the conversation and to move the conversation forward with new insights that might inform the next stage of research that we do in this space. So that's the kind of motivation behind what we are going to do today.
Thank you so much, Prof. I think I will also will request Dr. Bila Lamo, if we can get him to also give us his initial remarks on the intersection between suicide and the criminal justice system. Can we have him? Not yet. All right. All right. Okay. So we are giving Prof the opportunity to show a few slides with us. Right. Okay. So we have in our midst Professor Kwashi. Can you kindly have your seat here? Shall we welcome him? So as Prof Boakye is trying to give us some slides on the intersections. May I find out from you, Prof? Welcome. Yes, so this section is on suicide in Africa, prevalence, risk, and public perception. We all know that you have done quite an extensive work in this area. In fact, let me say that Professor Boakye is also a recipient for a global award on suicide research in Africa. So we have really an expert here, yes. And the beautiful thing is that that award was also preceded by, Professor Osafo, who also won a similar award earlier. All right, that is the Deleuze Award for suicide research in low and middle income countries. In fact, it's such a competitive award, and so it tells you that indeed we have the right people in our midst this morning to help us make a headway on this topic. So, Prof, a lot of work you have done. Is suicide an issue at all in Africa? What is the prevalence? What are the critical issues of suicide in Africa? Your extensive research.
Thank you very much, Johnny. So I think that in terms of estimates in Africa, the numbers are troubling in that, for example, when you take young people who are aged between 15 and 29 years, suicide remains among the top 4 causes of death. And when you take the global estimate together, Africa appears to be in the highest. I have always had a cause to question WHO's estimates of the issue of suicide, particularly on the African continent. Because when you look at, for example, and not just the recent estimate, when you look at it consistently from the year 2012 all the way to now, all the estimates that WHO has put out there will always place Africa as, at the lead. And then in the same report, you would find that WHO will say there aren't statistics from Africa. Then they conclude that Africa is in the lead. So the obvious question is, where are you getting the data from Africa? When you go in there, then they will say, based on some previous estimates, which, mind you, are not national level estimates that have been submitted to the WHO database. They based on that to model what could be the situation in the future. And so it becomes very difficult in terms of reliability of the estimates from the WHO. But what we need to understand is that a death by suicide is one too many. And the reason is because if someone dies by suicide, estimate from high income context, particularly where people are individualistic, the estimate suggests that at least the lives of 6 people are changed forever, in that they will live the rest of their lives questioning the reason for their death by suicide. And at least, again, 135 people will also be vulnerable as a result of their exposure to the death by suicide they know. Now, if you have to extrapolate this onto our context in Africa, where largely we are collectivistic, even though we can't say it is 100%, but we still have good traces of these attributes as a people. Where I meet you, you are a male, after 5 minutes of conversation, I begin to call you brother. Or if you're a female, I say sister. It brings that attribute out. And so you can imagine if, for example, in the US, 6 people are directly affected and 135 people are also affected. If you bring this to Ghana, for example, that would be huge. Because then somebody is somebody's father, or the person who has died by suicide is somebody's brother, somebody's sister, somebody's uncle, somebody's grandfather, and it goes on, friend, co-worker, and so on. And so the numbers are big. So the point is that perhaps the numbers, in terms of the estimate by the WHO or any other body, will add more to the seriousness of the situation. But the point is that a death by suicide is preventable. And so if somebody dies by suicide, it is problematic. And so it's good that we pay attention to the situation, particularly the issue of data, and that has been the biggest issue. Just about 3 days ago, we had a global webinar by the International Association for Suicide Prevention, and the key thing that came up was that, look, it's about time we started training more people in terms of researchers for the sub-region, particularly sub-Saharan Africa, where people will get to understand the main methodologies that are needed, that people will understand the main issues and the contextual issues that will help us understand and appreciate the extent of suicide in our context. And so as academics, I think it's on us as a duty to consider nurturing more researchers into the space. People need to understand the appropriate language and methodologies for researching the phenomenon of suicide. So in the end, we'll be able to appropriately inform intervention and prevention efforts and programs. Thank you very much.
Thank you, Prof. Thank you, Prof. I would like to also find out, as far as I'm concerned as a Ghanaian, suicide is a topic that is not mentioned. In fact, we classify it, among a class of teams we call amboding. We don't mention them. So in effect, what you're saying is that maybe the numbers even at WHO may be an underestimation. But how do we then navigate, a context like this, right, to research suicide? A place where suicide is tabooed, we don't talk about it, and yet we still have to know about it. How have you navigated it?
Thank you very much. Yes. So until 2023 March, Ghana had kept the anti-suicide law from the year 1960. And the paradox about that law then was that it was an inheritance from British colonial rule. We got it in 1960, and exactly a year after, the British repealed that law. And we kept it all the way until 2023. Now, what I'm trying to say is that the repeal of that law is a massive step, massive step towards working our way through bringing down the stigma and so on. Because remember, anything that is a behavior that is criminalized is likely also to be automatically stigmatized. And so once we take away the law, then we know that at least we will have the support of government towards bringing down stigma and all the related, negative social attitudes and so on. But we also need to understand that before the adoption of that law in 1960, as a people, we already abhorred suicide. It was prescriptive. So even though we have taken the law away, we still have to deal with the traditional setup within which the behavior is still abhorred and is a taboo. That is one leg. The other leg has to do with our religious circles, where all the religious groups in Ghana also classify suicide as a sinful act. And so even though the law is away, we still need to do a lot of work. And I'm happy that at the moment, we are putting in some efforts, engaging with religious leaders, running training workshops for them, engaging with traditional leaders, running training workshops, workshops for them, and letting them understand the evidence we are gathering from the ground and the reason for ensuring that people change their attitudes towards suicide and suicidal persons. Another area we are trying to plan a project for is how do we get data not just from the clinical context but also from the community context? Because remember, attempted suicide is always higher than deaths by suicide. And so now the Ghana Health Service is trying to gather some data on suicide. They are gross underestimations. Remember, if somebody dies by suicide in an Islamic community, within minutes, the person must be buried. And so that data will never get to the hospitals or clinics, and so we won't capture that. If somebody dies by suicide, even though the law has been repealed, families will take their body to the hospital and they will change their verdict that it was by accident or whatever. Some also will change their verdict because they want to be sure that they get the insurance and things like that. And so we need to do a lot, particularly capturing data within the community context. And here we are planning of engaging with key stakeholders like, religious leaders, particularly our Islamic religious leaders within the community. And then also, of course, the other religious groups, their leaders and traditional leaders and opinion leaders, so that when people, die by suicide or when people are suicidal, they can step in as gatekeepers or mental health first aid providers to step in order to avert the suicide completely. And so these are some of the efforts we're trying to put in place because we believe, not just in the Ghanaian context, but globally, more of data related to suicide and suicidal behaviors are within the community setup other than the mental health or the health sector. And so those are some of the things we're trying to do. It's not straightforward, it's not easy, I must confess, because suicide, as we all know, is a heavy topic, and so many people would rather move away from it. Evidence suggests that even psychologists who have training, once they are alerted that, okay, we want to bring you this person who has attempted suicide, they find every good excuse to avoid that client because it's difficult. Suicide is not one of the subjects in the medical schools or even our mental health training setups. But thankfully, it's one of the key things that have been explicitly mentioned by the SDGs. And so we need to pay attention to it and deal with it head on. Right. Thank you.
Wow. These are very commendable efforts. Oh, can we give it to him? I mean, this is a very great delivery. But Prof, you mentioned in your initial remarks that you got some funds to do a research on suicide risk and the law. Yes. Can you throw some light, on the key findings of that research?
So,
yeah. What did you
Johnny
find?
has just landed straight into the presentation, so I'll just do that because part of the data I'm presenting is from that project. Okay. I hope this works. And I should say that we've got our colleague in Cameroon online, so okay. He has got a really important presentation to make from the Cameroonian context. So just to acknowledge him.
So as the presentations are going, you can put down your questions, and when the time comes, you can have a lively Q&A.
Yeah, finally, we're here. So thanks very much. So what I'm talking about is a background, and then I'll end with what we are thinking about doing, okay, and what we've already started out. So this was one of the projects that I'm particularly proud of, led by the department and colleagues here. I don't know where to start, but hopefully, or sit. So this project was led by Professor Osafo and myself as Kofi, and colleagues here. I think Johnny was part of this project as well. Johnny and my good friend Ima is also part of it, Kweshi. what we started off was to look at a broad, again, to take the issue of suicide a little bit further. So the interdisciplinary angle was featured in this project. It's one of the few projects that took a mixed method approach to understanding suicide. So we had a qualitative element and a quantitative element. What I'm presenting with our colleague Winifred, who is also not here in Australia, is about 1 a.m. there, so she said, apologies, she could not join online. But we are trying to develop a paper right now as a baseline. Now that, as Dr. Kofi said, or Prof said, suicide is now decriminalized since 2023. But what we don't have is a large-scale survey that provides a baseline. And I'll explain why a baseline study is really important, especially when you decriminalize suicide or any other crime. So I'll talk a bit about baseline and the context and the method results, and I'll end with some reflections on what we are thinking about doing next from an interdisciplinary perspective. Much of these statistics, Dr. Kofi has elaborated on them, so I won't spend too much time on that. We all, for those of us who work in this field, we're very familiar with the data. It's alarming as far as suicide is concerned, and particularly when it comes to the African context. He's also exposed on some of the problems with the data, which we all acknowledge. And it's the challenge is on us to be able to provide the alternative measure of suicide. Otherwise, the WHO and international organizations have no choice but to continue to rely on these unreliable and inaccurate data sets. But at least it's a starting point to help us unravel some of the challenges in relation to suicide. So you can see, in terms of the current evidence and the data that we have, Africa is marked as one of the key areas where suicide is particularly prevalent, particularly among young people, the youth. So it's an important, and when we talk about youth, oftentimes the WHO data will talk about 15 to 29, and we have questions around that, but that is the estimate that they tend to rely on. So it's a particularly important issue, not just in Ghana, but in developing countries. As Kofi said, it's specifically mentioned in the SDG, so this is a really important issue that we need to think about. Okay. It's an important issue that we need to think about, and to be able to build the evidence to inform some of these mental health action plans that are more relevant to our specific context. Already there is a recognition also that suicide is a mental health crisis, all right? And that is the basis on which we have advocated, and particularly led by colleagues in the department here, we have advocated really strongly for it to be decriminalized. And here I should commend Prof. Osafo and the team in Ghana for spearheading. I know that there have been many workshops, some of which I participated in, several submissions to Parliament and presentations. So that didn't come cheap, and I think it's important that we recognize those efforts. So these are key milestones, and it's good that we are here thinking about suicide and talking about suicide freely for the first time, not actually criminalizing or trying to see those who have attempted as people we should report to the police. But when you talk about reporting, you're talking about the criminal justice system, which I'm particularly interested in, and the processes that one goes through. So I was fortunate to give a guest session last 2 weeks or so with the MPhil students on mental health and the law, and we deliberated on some aspects of the Mental Health Act and how the challenges that individuals might face. In reality, although in paper you have decriminalized, in reality what actually goes on is something that we need to reflect on, and that's the dimension that I'm going to take you in a few minutes. So yes, you've decriminalized, and Professor Kofi said, then you have the stigma to deal with. it's almost like the chicken and the egg situation. Did we have it as a taboo before the law was passed? And if we didn't have colonial rule, would we have not passed a law to reflect our morals or social standing as far as suicide is concerned? So it becomes a complex issue. This debate is also happening in another project I'm involved in, which is the death penalty. All right, the death penalty is a colonial introduction, but there is a serious contention as to whether we had it before colonialism. It's just that it didn't exist in law. But in our tradition and custom, this would have been criminalized. All right. So there is that debate going on. And thankfully, we've got the law also amended on the death penalty. But we still have a few other challenges to clear as we go along. So these are two projects that are particularly dear to my heart. I mention stigma because it seems, if you look at the evidence elsewhere, the current reviews that we are doing for a paper suggests clearly that it's probably easier to deal with the decriminalization than to deal with the stigma. And so once you decriminalize, it is not the end. It's actually the beginning of a very difficult journey. One of the interesting things that has happened in Ghana, and I'll end with that, lessons we are learning from the Ghanaian context for another project. One of the lessons we are learning in Ghana is it's highly unusual to have public opinion so strongly in support of something, and yet government goes ahead to still enact a law that changes or amend or decriminalize. Oftentimes, politicians are very, very sensitive to public opinion. And so all the evidence, as I'll show you in a minute, suggests that it shouldn't have happened. Again, reinforcing the role of advocacy and the importance of research and working with policy and not waiting for public opinion to change before you change policy. And there is that common narrative also in the UK when it comes to things like death penalty and others, where the government did not wait for public opinion to change. So sometimes policy can actually drive public change. And that's the context in which I would talk about this study. So quickly, this is one of the few, I don't know any large-scale quantitative study in Ghana on specifically on public opinion on suicide. There are other studies that I know are emerging, quantitative studies, including in the university context, that takes a broader approach. But this was one of the few and first projects that tries to move in that direction. As I said, it was a mixed method, but I'm just focusing on the quantitative aspects. So we did a random sample of households, and this is the criteria we used. And we had sites. We used criteria to make sure that we are able to cover, and this is just in Accra, it's not a nationwide study, to try and cover different neighborhoods so that it's reflected in the context. High-class neighborhoods, low-class neighborhoods, indigenous neighborhoods, so that we can capture the broad range of views within this particular context. The instrument we used was quite detailed. We spent a lot of time developing a very detailed instrument. I am not presenting everything here. I'm just focusing on the attitude side. But we had elements on risks. We asked people what, in their view, do they consider to be risk factors for suicide? And then we went on to actually assess their own views on suicide, as well as risks at the psychological level, at the family experience level, and neighborhood level. So there is a broad range of details in these data sets. Examples include questions like this. There is no justification for someone killing him or herself. Taking your own life is the worst thing you can do to your family. Killing oneself is a serious taboo. I think attempting to kill oneself should be considered a very serious crime, and so on. There are many other studies questions that we have on the questionnaire. Now, I hope you can see this. We had about 500 sample, and we look at male, female. So this is the distribution in terms of the demography. I won't spend more time on it. More female than males in the sample. We have all kinds of age range represented, as well as educational background, And Professor Kofi mentioned religion. So we're very interested in religion as well. We captured that in this study. And we looked at religious importance. So there's a difference between someone saying, I go to church, and actually someone taking their religion very important. And those can influence attitudes differently. So we have captured all of that. In terms of prevalence, as you can see in the sample that we had, we asked questions about attempted suicide, we asked questions about expressed suicidal thoughts, and we also asked questions about wishing to die by suicide. And as you can see, thankfully, the number is not that high, but if you work within the space of suicide, you know this is troubling. Okay, 8.4% who have attempted is quite high in that respect. But as you can see, this is an interesting pattern we've observed here. Some of the key findings in terms of age and suicide attempts, you can see from this data that the very young and the very old. So that is why we have a third panel with a focus on the older person, because you can see this trend. And even our anecdotal evidence before this evidence shows clearly that when you talk to very young people, they are in the crisis phase, they are identity crisis phase, and that may be informing some of their thoughts and thought processes. And this is reflected in the data set. 4.5 we found in this data set for the young and the old. In terms it was Catholics, in terms of relations, seems to have a more relaxed view towards suicide, and that appeared to reflect in this data set. The other group of people that we could data set as far as religion is concerned. Neighborhood. We had high-class neighborhood, middle-class neighborhood, low-class migrant neighborhood, and then we have lower-class indigenous neighborhoods, because that is not necessarily a poor or a rich neighborhood. But these are contexts that you have a lot of indigenous people living in. And then we also did some specialized interviews with prisoners. And we just finished another study on prison that I want to talk about in October. Hopefully we can address that bit. In terms of possibility of considering ending one's life, the data was quite clear. Majority are not considering that, but at least we have a good number, about 5.1%. So together you're talking about 7%, again reflecting the pattern that we found. Preference for type of death. So if you were thinking about dying, what would be your most preferred means of death? The majority obviously would like to grow to a very old age before they pass on. But again, it's quite interesting that there is quite a number that would consider suicide as an option. And we were particularly interested in this. So we pushed them a little further by asking, under what condition would you be considering to actually end your life? And we have persons talk about incurable disease, when they have incurable disease. So you can see the link. We're trying to run a correlation between this and age to see the correlation between that. So older person as neglecting suicide project needs to be brought back into the equation if we are very serious about tackling suicide issue here. STD infection was about 4.5, not able to care for family. And you would think about the young. Again, we're doing the correlation here. If you are a breadwinner, you can afford. What are your options? And loneliness has been one of the key driving factors, particularly in Western countries. So we introduced that here to see in our community, the nature of the community, would loneliness still be an important factor? And it seems to be gaining some currency here. And then you have knowledge about suicide. If you want to test people's attitudes to suicide, you must first start from whether they have even sufficient knowledge about suicide at all, because knowledge can influence your attitude. So we started from there, and as you can see, the majority knows nothing about suicide. So that's, if you want to tackle stigma, this is one of the things you have to identify. and that should inform your intervention strategy. The majority are not informed, and therefore the decisions they made is based on something else rather than particularly accurate knowledge of suicide. Level of interest. When before the law, I said this is a baseline study, before the law was decriminalized, we wanted to know how much people took interest in this. Again, you can see that the majority were quite, some were interested, but the majority were not particularly looking at that because it's not close to you until it actually happens. And then knowledge of the law and arrest for suicide. We also teased out that. Is suicide a crime? The majority said yes. I presume this was a guess from the majority because they are picking from the taboo to try and inform what they think about the law. Have you heard anyone arrested for attempted suicide? About half said no, they have not. Know anyone arrested for attempted suicide? Again, the majority said no, they don't. So almost always, it appears that knowledge of suicide is based on vicarious learning rather than direct experiences with a close one. Again, you need to factor this into your advocacy strategy. Suicide disapproval and support for criminalization. The majority support criminalizing suicide. So you have an issue here to deal with, right? The majority support criminalization. So this is where I really commend those who have advocated in this space. Because within this scenario, it's not easy. The evidence everywhere shows that policy and public opinion usually should go together. Otherwise, you are risking your political position. And so this is a really important point to take note of. Then we did some simple analysis, and I didn't want to bore you with too many detailed analysis at this point. So we just did a simple analysis in terms of socio-demographic characteristics, and you can see an interesting thing happens with age, gender. If you take males, the majority support criminalization compared to females. Okay, so we also assessed psychological and personal characteristics. So empathy will be one thing that will correlate with these factors to see how it plays out. And then attempted suicide, are you in support? We did the analysis in relation to that. But where I want to focus on is this, and then maybe I'll skip the other ones. I'm mindful of time. Religious affiliation, so and support. So you can see that in terms of the affiliations, it was significant, not that strong, but you could see that the difference between the various religious groups matter. So if you are taking your message within this context, you have to be able to tailor the message. You cannot assume that all Christians would necessarily hold the same views when it comes to suicide. And that's something that we're going to highlight in this paper. Kofi mentioned Islam. You can see the high number of disapproval among Islamic societies. So that would influence how they communicate the verdict to any health professional, because that's something that you don't want to be associated with your family member. So you will change the narrative at some point. We also had age. I will skip that. If you have questions, we can talk about that, and education. And this I find interesting. Again, education was significant. And you could see that the more educated you are, the less likely you are to support criminalization. And that's an important thing. And the question we need to ask there is it formal education? Or some form of education can help in terms of destigmatization? And that's something that I think is a challenge for those working in this space to figure out based on previous research and future reflections. I'll skip high class and low class neighborhoods. So where am I getting to? I'm getting to a point where we say minimal public knowledge of suicide. We know that. And that's an important thing to factor into a strategy. Attitudes are based on inaccurate knowledge. Okay, and so if you feed them with the accurate knowledge, then you are more likely to reduce stigmatization. Decriminalization should be considered as the beginning, I've mentioned that, and not an end in itself. And finally, it's important that this work provide that baseline. And what we are trying to do is not to end here. We will do repeated public attitude survey, focusing specifically on the stigma aspect. And I believe that this is an important thing to build into any intervention. So for those of you who are thinking about studies in this space, it's important that as you do the advocacy, you also take before and after measures to be able to assess how effective. Because sometimes we gather people into a room and we talk a lot. And academics, we like talking. So we talk a lot at them without actually engaging them. And then we feel very good about ourselves when we leave and say, we've done our job, right? It's really important that we have an evidence-led approach and we can track destigmatization over time to see where we were when there was criminalization and where we are 20 or 30 years down the line. And that I think would help everybody, especially attempters or survivors who need public support. What we're doing currently are two things. One is we've already gotten funding for a project in Malawi. And we are drawing heavily on the lessons in Ghana. So in Malawi, suicide is still a criminal offense, all right? And so are about 25 other countries on the continent. So our work has just begun, not an end. And I think lessons learned from each African countries, which is hence the panel, will help in understanding the specific context, as well as what you can learn from these other contexts to help with the advocacy work in this space. And then we are hoping, next year, we are hoping to put together a bid specifically on youth and mental health. And that is one of the key things we hope to do from an interdisciplinary perspective. So if you're a researcher here who is interested, this is something that I would really like to talk, to discuss, to see how best we can put together a really good team to be able to assess funding. Because oftentimes, as Professor Kofi said, the research is not there. Why is the research not there? There's no funding. It's not the expertise. I know a lot of colleagues here who are really doing amazing work with the little resource that they have. And I think it's important that we start to pool our strengths together to see where the fundings are and to try and access these fundings for the projects that we want to build in this space. So that's me with so much.
Thank you, Prof. Thank you, Prof. Please, let's do it better for him. Yes, it takes a certain conviction to do research on suicide because, as we all heard, the topic itself is emotional laden, and it is not easy. But I think we are very happy with this insight shared. And I like the point you just mentioned, that without education, suicide myth will continue to prevail. And most of the times, the attitude towards suicide is because there are a lot of myths in there. Human beings, naturally, we are sense-making people. So where there are no knowledge, we try to create explanations for things. And so it's important that research of this nature at least helps us, to fashion some, educational, programs, just so people will come to know that this is not a crime, this is not a sin, but it's really life crisis, and opinions matter when we want to effectively intervene. Thank you so much, Prof. I think at this stage, we would like to give Dr. Lamo, if we can take his remark. Yes. And then we proceed. All right. And let me say, Dr. Lamo is from Cameroon. Good. So we need everybody on board. As Africans, we need to come together, all right, and fight this menace. So happy to see that some collaborations are going on among some Africans. Very, very good step in the right direction. Okay. Hello, Dr. Lamu.
Bonjour.
Good afternoon. How are you?
Bonsoir.
Good.
Bonjour à tout le monde. Bonjour au panel.
Good morning to you all.
Dr. Lamo, please, are you there?
Ok, je suis là.
Alors, vous êtes là?
Ok,
Yes,
je
I'm
suis
there.
là.
Yes, I'm there.
Yes, so we have an interpreter for you, all right?
Nous avons un interprète pour vous.
Yeah, so you share your insight, your remarks, with us on suicide in Africa, prevalence and then risk and public perception. Your remark on this topic, and then it will be interpreted
Donc,
to the audience here.
on vous attend pour, n'est-ce pas, partager ce que vous avez pour nous cet après-midi.
Ok, bonjour à tout le monde et je suis très content de participer à ce panel consacré à un sujet d'actualité, le suicide en Afrique.
Good morning to all of you,
Et
and I'm
ma
happy to be part
présentation,
of this.
est-ce qu'on me comprend? Voilà, donc on m'a demandé donc de présenter l'état des lieux du suicide au Cameroun. C'est ce que je vais vous faire tout à l'heure. Dans la prévention du suicide au Cameroun, état des lieux. C'est une présentation qui est présentée par l'Association camerounaise de prévention et de lutte contre le suicide, qui est une association qui date de 2019 et qui mène des actions de sensibilisation auprès des populations pour leur faire comprendre que le suicide est une réalité africaine et qu'il y a des moyens de prévention à l'exemple du dialogue. C'est la raison pour laquelle notre association est dénommée a pour slogan « Le suicide, la solution, c'est d'en parler ». Et nous aussi, nous sensibilisons aussi, nous interpellons les gouvernants, les décideurs, pour qu'ils puissent prendre les politiques publiques afin de prévenir le suicide au Cameroun. Je ne sais pas si on peut traduire ou bien je continue directement.
Oui, on peut facilement faire la traduction et je suis prêt pour le faire.
Je peux continuer directement ou bien vous traduisez d'abord?
Oui, j'ai fait la traduction ici.
D'accord.
Donc, il faut s'il vous plaît aller doucement. Comme ça, on peut vous écouter bien.
Allô?
Allô, oui, on vous écoute.
Oui, je continue.
Oui, vous pouvez continuer, s'il vous plaît.
Ok. On va donc à la présentation de qui suis-je? Je passe au slide 3.
Okay, Dr. Lamo, yeah, so someone is translating what you're saying, so just take it one by one, and then it will be translated for our audience here. All right.
Ok, et ici, ça, c'est la première page de notre communication qui est basée sur l'état des lieux du suicide au Cameroun. On va essayer de dire ce qu'il en est de la prévention et de la prise en charge du suicide au Cameroun. Next slide.
Next slide.
What did he just say?
Patientez-vous, s'il vous plaît.
Okay.
So it's about case study in Cameroon concerning suicide, prevention, measures, and that is what we are here for.
Okay. All right. Okay. So, Dr. Lamo,
We're working on the slides.
Yes. So, Doc, we are trying to avoid a challenge here. So you just go ahead and then share your slide, read whatever is there, and then it will be translated here for you.
Okay.
If that's okay with you.
Ok, je suis donc Alain Bila, président de l'Association camerounaise de prévention et de lutte contre le suicide, et je suis le coordonnateur sous-régional des pays africains francophones de l'Association internationale de prévention et de lutte contre le suicide, et par ailleurs formateur international en prévention du suicide sous le shop.
Can you translate that? What he just said.
That's technology.
Yeah. So
You commence?
if you can repeat to him what I said, that he can go ahead. read the
Please,
slides.
vous pouvez continuer.
Then he will translate for us.
Ok.
Et je vais faire la traduction.
Le plan de mon exposé est présenté ainsi que suit. Nous avons le contexte général de définition, les données statistiques sur le suicide au Cameroun, les facteurs de risque, le cadre institutionnel, les initiatives de prévention et les acteurs impliqués, les défis majeurs identifiés et les recommandations.
Please, you can see from the screen, we have been able to do a translation, and so we just go ahead and follow.
Voilà. L'Organisation mondiale de la santé, OMS, estime qu'environ 7300 personnes meurent de suicide chaque année. Et 80% de ces suicides-là surviennent dans les pays à revenus faibles et intermédiaires. Le Cameroun est le 5e pays en Afrique où on se suicide le plus sur une population de 100 000 habitants. Et toutes les 40 secondes, que ce soit pour des raisons de déception amoureuse, d'atteinte d'une maladie chronique, d'épuisement professionnel, d'harcèlement, de maltraitance, d'échecs scolaires constatés chez les élèves et les féminicides, les individus, pour une raison ou une autre, optent pour le passage à l'acte comme moyen de solution. Au Cameroun, le suicide est un problème de santé publique majeur et reste un sujet tabou, peu documenté et largement négligé par les politiques de santé publique. Pourtant, les facteurs de risque sont nombreux et croissants. Instabilité sociopolitique, pauvreté, conflits armés, stigmatisation des troubles mentaux, isolement social, etc. Cet exposé présente un état des lieux de la prévention du suicide au Cameroun en mettant en lumière les données disponibles, les facteurs de risque, les réponses institutionnelles, les initiatives communautaires, ainsi que les lacunes et recommandations prioritaires. On est ensemble?
Oui, vous pouvez continuer. On peut regarder ça sur l'écran.
Non, je ne vois pas le tableau.
Ah, c'est pas clair?
C'est pas clair, c'est tout blanc.
C'est tout blanc. Ah bon. Mais pour nous, on voit tout ici. Et tout ce que vous êtes en train de nous dire, c'est très clair.
Ok.
Donc,
là, je suis au niveau maintenant du contexte général.
Oui, justement ça. Donc, vous pouvez continuer.
Voilà. D'accord. Qu'est-ce que le suicide? Le suicide est l'acte de mettre intentionnellement fin à sa vie. Il s'agit souvent de la dernière étape d'une grande souffrance psychique, émotionnelle ou sociale qui n'a pas trouvé d'issue. Le suicide n'est pas un choix librement éclairé, c'est souvent une tentative d'échapper à une douleur insurmontable. Il peut concerner n'importe qui, quel que soit l'âge, le genre, la religion ou la situation sociale. Next slide. Le suicide au Cameroun, une urgence silencieuse. Au Cameroun, le suicide est rarement abordé dans l'espace public.
S'il vous plaît,
et
une minute, patientez-vous. Il y a un petit problème chez nous.
Ok.
Pourriez-vous continuer, s'il vous plaît?
Voilà, je disais tantôt qu'au Cameroun, le suicide est rarement abordé dans l'espace public. Et cela, c'est le tabou qui entoure cela.
Alors,
on n'en parle pas trop.
Alors, il faut un peu aller en arrière. Un peu en arrière.
Ok. Au niveau du contexte général.
C'est ça.
Ok.
Merci.
Bon, je reprends donc. Qu'est-ce que le suicide?
Oui, c'est ça.
Voilà. Qu'est-ce que le suicide? Nous définissons le suicide comme l'acte de mettre intentionnellement fin à sa propre vie. Il s'agit souvent de la dernière étape d'une grande souffrance psychique, émotionnelle ou sociale qui n'a pas trouvé d'issue. Le suicide n'est pas un choix délibéré ou éclairé. C'est souvent une tentative d'échapper à une douleur insurmontable. Il peut concerner n'importe qui, quel que soit l'âge, le genre, la religion ou la situation sociale. C'est bon?
Ça va.
OK, next slide.
Maintenant, nous sommes
Le
sous
suicide
les...
au Cameroun. Le suicide au Cameroun,
Non,
une urgence.
on est avec les approches, quoi. Les approches utilisées.
Ah, OK, ça veut dire que vous avez sauté. OK. Les méthodes les plus utilisées.
C'est ça.
OK. Au Cameroun, les méthodes les plus utilisées pour mettre fin à sa vie, c'est sans faire une publicité dans les méthodes de suicide. Hein.
Okay.
Il y a les injections de produits toxiques.
Vas-y, vas-y. Vous êtes avec nous, s'il vous plaît?
Pesticides, les médicaments, tués par arme blanche ou arme à feu. Les zones géographiques touchées.
Allô? Allô? Monsieur, on vous écoute.
OK.
Nous sommes sur les risques, les risques des facteurs.
Les zones géographiquement touchées au Cameroun. Les zones géographiquement touchées au Cameroun sont, il y a la région anglophone qui vit une crise sociopolitique. Il y a également l'extrême nord avec l'insécurité et la pauvreté. On sait qu'il y a la guerre du Boko Haram à ce niveau-là. Ça crée une instabilité au niveau de la sécurité.
Alors,
Toute chose qui a donc une influence sur la santé mentale des populations. Il y a également les zones urbaines à forte densité, à l'instar de Douala et Yaoundé, qui sont des zones assez touchées par le phénomène. Les facteurs de risque spécifiques. Les facteurs de risque spécifiques au Cameroun. Nous avons l'instabilité sociopolitique et conflits armés. Nous avons dit le cas des régions du nord-ouest et du sud-ouest et l'extrême nord. Les traumatismes psychologiques chez les déplacés internes et réfugiés. Nous avons également le chômage et la précarité économique, le fort taux de chômage chez les jeunes diplômés qui peuvent être à l'origine des cas de suicide. On est ensemble?
Oui, on est ensemble.
OK, le chômage et précarité économique également, l'absence de perspectives professionnelles. Les facteurs de risque spécifiques au Cameroun, nous avons les violences basées sur le genre, des mariages précoces, des violences domestiques, agressions sexuelles, troubles mentaux non pris en charge. Nous avons également la dépression, les troubles anxieux, les psychoses sans diagnostic ni traitement. Les facteurs de risque encore spécifiques, nous avons la stigmatisation sociale et religieuse, la peur de la honte familiale, croyances liant suicide à la sorcellerie ou à la faiblesse spirituelle. Nous avons également l'isolement et problèmes familiaux, rupture affective, perte de proches, conflits familiaux. Le cadre juridique. Il faut déjà dire ici d'emblée que le suicide n'est pas criminalisé au Cameroun. On est ensemble?
On est ensemble.
Ok. Le suicide n'est pas criminalisé au Cameroun. Aucun texte légal au plan stratégique spécifique à la prévention du suicide n'existe à ce jour. La politique nationale de santé mentale. Le ministère de la Santé publique reconnaît la santé mentale comme une priorité. L'intégration progressive dans les soins de santé primaire, mais couverture encore très faible. Les infrastructures en santé mentale. Nous avons les centres psychiatriques principaux, hôpital Jamo de Yaoundé, hôpital Lakentini de Douala, Garoua, Marois. Les statistiques montrent qu'on a 15 psychiatres, dont 3 en clientèle privée, 200 infirmiers spécialisés en santé mentale, 30 psychologues en clientèle privée, plusieurs prestataires socio-sanitaires et nous avons également les filles de cerveau. Le ministère de la Santé publique forme de temps en temps, de manière ponctuelle, sur la santé mentale et aussi en organisant la journée mondiale de santé mentale qui se célèbre tous les 10 octobre de chaque année. Il y a une manifestation qui est organisée par le ministère de la Santé, mais pas une organisation qui est axée sur la prévention du suicide, qui, elle, se célèbre tous les 10 septembre de chaque année. Nous avons également des appuis aux hôpitaux psychiatriques, la participation aux campagnes de sensibilisation, les initiatives de prévention et acteurs impliqués, les associations. Au jour d'aujourd'hui, on ne nombre que l'Association camerounaise de prévention et de lutte contre le suicide, qui mène des activités. Oui.
Paraît-il que vous avez sauté un peu, quoi?
À quel niveau?
On est sur les recommandations continues.
Ah, les recommandations viennent à la fin. Hein. Ça veut dire que mon slide a été désorganisé.
Donc, revenons à nos moutons, s'il vous plaît.
Ok, les associations d'abord. Les associations.
Vous pouvez
regarder à ce jour. Pardon?
Vous pouvez nous regarder ici?
Je n'arrive pas à voir.
Ah bon? Sinon, chez vous, ce n'est pas clair.
Je ne vois pratiquement pas, en fait. C'est tout blanc.
On est sur, n'est-ce pas, les problèmes majeurs identifiés, quoi?
Ok, les problèmes majeurs identifiés.
S'il vous plaît, oui.
Are we done?
1 minute. Please.
Okay.
Ok. Les défis majeurs identifiés.
Oui.
Voilà. Il y a l'insuffisance des données fiables. L'insuffisance des données fiables.
C'est ça.
L'absence de système national de collecte de données par le suicide. Il y a un manque de financement. Le budget très faible alloué à la santé mentale est insuffisant. Moins d'1% du budget de la santé publique. Nous avons également insuffisance de professionnels formés, manque de psychiatres, de psychologues, de travailleurs sociaux. Au niveau gouvernemental, élaborer un plan national de prévention du suicide, intégrer le suicide dans les statistiques nationales de santé, allouer un budget dédié à la prévention du suicide, développer des centres d'écoute et d'intervention d'urgence. Au niveau communautaire. Prochain slide.
Oui, on est là.
Au niveau communautaire,
Oui.
le renforcement de la formation des sentinelles en prévention du suicide. Il faut le dire que notre association a mis en place un projet de formation des sentinelles, des personnes qui peuvent détecter la souffrance psychologique auprès de l'entourage afin d'arrêter les drames. Intégrer la santé mentale dans les écoles et les lieux de travail, favoriser les campagnes de sensibilisation et stigmatisantes. C'est la raison pour laquelle nous organisons chaque année la journée mondiale de prévention du suicide, qui est un moment pour nous de sensibiliser les populations sur ce tueur silencieux. Au niveau des partenaires techniques et financiers, soutenir les projets pilotes de prévention communautaire, accompagner la mise en place d'une ligne verte nationale, promouvoir la formation continue des professionnels de santé. Et là, je suis en conclusion.
C'est ça.
Le suicide au Cameroun demeure une réalité silencieuse, bien que croissante. L'absence d'une stratégie nationale cohérente, le manque de ressources humaines et financières, ainsi que la stigmatisation sociale renforcent la vulnérabilité des populations à risque. Pourtant, les leviers d'action existent. La sensibilisation communautaire, le renforcement des systèmes de santé mentale, appui aux initiatives locales, une approche multisectorielle et décentralisée est indispensable pour sauver des vies. Quelques numéros utiles.
OK.
Nous avons le MinSanté. Quelques numéros utiles. Nous avons le MinSanté. Le 1510, c'est le numéro que le ministère de la Santé publique du Cameroun a mis en place pour soutenir les personnes en détresse psychologique. Cette ligne est disponible 24/24, 7 jours sur 7, et au bout du fil, vous pouvez avoir un psychologue qui peut vous répondre. Nous avons aussi l'ACPLS, l'Association camerounaise de prévention et de lutte contre le suicide. Le président que je suis, Alain Bila, qui répond au numéro qui va s'afficher, le 693 36 70 89 et le 675 25 58 27, suivi de l'indicatif du Cameroun, le +237. Merci pour votre aimable attention.
Merci.
Thank you.
Merci
Thank you.
également.
Thank you.
Merci également.
Merci beaucoup. Merci beaucoup. Merci beaucoup.
Merci beaucoup.
Merci beaucoup.
Merci également.
Merci beaucoup. Thank you so much, Doc. Yes, indeed,
Hello.
we need. Yeah.
It has to do with suicide case study in Cameroon, preventive measures, and then things that are happening there, percentages to match, and funding programs that have to do with suicide. They have recommended a lot of things there. I think with the slides, he was very faster than what was going on here. So I had to alert him. But I'll beg that we all have access to the slides.
Sure.
And then
Sure.
we have an in-depth talk
Prof,
due to time.
Is he gone or is still on?
Alors, vous êtes toujours là, Prof?
Je suis là.
Yes, yes.
Oui,
So
il y a des questions.
Yeah, just one
Il y a des
quick
questions
question.
pour vous.
One quick question.
OK.
Yeah, Doc,
Okay.
so
Il y a une question pour vous, s'il vous plaît.
Yeah. We could glean from your presentation that suicide is still criminalized in your country. What future do you see for decriminalization? Are there any efforts towards decriminalization of suicide anytime in the few years ahead?
Oui, Prof, il y a une question ici. C'est que, d'après votre exposé, c'est très clair qu'il y a la décrimination de ce phénomène. Qu'est-ce que vous êtes en train de faire pour, n'est-ce pas, éviter ce phénomène? vis-à-vis l'avenir.
Déjà, merci pour votre question. Merci pour votre question. Et j'aimerais dire tout de suite vraiment que le suicide au Cameroun n'est pas criminalisé. Et je l'ai mentionné dans mes propos. Le suicide au Cameroun n'est pas un crime.
In Cameroon, it is no more a crime.
Okay, good.
Le crime au Cameroun serait de publier un cas de suicide d'un mineur.
Their intention is to publish whatever goes on in the nation.
All right.
So for them, it's not a crime.
Very good. All right.
Non, voilà. Non, c'est pas un crime.
Merci beaucoup.
Thank
Prof.
you so much. Thank you so much, Doc. Yeah, so I think you are also making steady progress there. We just need to work together, as people sharing the same, risk factors and having common mental health challenges. We need to work together towards, effective remediation of the issue of suicide. We all know very well that...
On est vraiment reconnaissant de vos efforts et nous sommes là pour travailler ensemble pour le progrès de l'Afrique.
C'est ensemble que nous pouvons réduire le nombre de suicides en Afrique. Nous serons très contents de travailler avec vous.
C'est ça, l'unité fait la force.
Voilà.
Thank you so much. All right. So, audience, I want to believe that you have many questions, put down. But to maybe, with your kind indulgence, Prof, for us to make a maximum use of the time here, maybe we can quickly take the second panel discussion. Yes, and then we can ask the questions together, just so we can leave here on time. So can I humbly invite, yes, Prof is already here. Prof is already here. Prof Kofi, you are not going yet. You are still around, right? So you sit down. We will certainly ask certain questions from your presentation. Right, can I have my dear sister, Irene Boakye, to join us? Let's welcome her. Irene Boakye, yes. She is a PhD student working on suicide. We are making steady progress in Ghana. This is a topic that used not to be researched. Now we are having students who are doing it at the master's and PhD level, and Irene is one of those students. We also have Miss Beatrice Jumfo Williams. Are we having her here? Beatrice, I cannot see her here. But we have Miss Tichilayo Tadi. She's online. All right. Can we take Miss Tichilayo Tadi's presentation quickly? Good
afternoon, everyone.
All right, she's speaking. All right.
Good afternoon, everyone. Can you hear me?
Yes, we can hear you loud and clear. Mr.
All right, good afternoon, everyone.
Welcome to this session.
Thank you very much. Thank you for having me.
Thank you so much. We are trying to look at youth suicide and mental health in Africa. Can we take your initial remark on the topic, youth suicide and mental health in Africa? We can hear you loud and clear here.
Thank you very much. I was going to share some slides, but it looks like I can't share it. So maybe I'll just speak to the slides. I'm not allowed to.
Yes, you might go ahead. We can hear you clearly.
Okay. So my name is Titilayo Tadi. I'm a social worker. I work at a teaching hospital in Lagos, Nigeria. But I also work with an NGO called Suicide Research and Prevention Initiative in Lagos. Well, it's national now, so don't let me say in Lagos, Nigeria. So SERPIN started as a result of, I'm going to just give you a brief result of why SERPIN, we started. In 2017, in Lagos, we saw somebody who took his life by suicide. And it was somebody that, for a lot of Nigerians, it was atypical of what they expected of somebody who was suicidal. This was a young medical doctor who had a good job, seemed to have everything going for him. And, he financially seemed stable. So they couldn't understand why. And what happened was he asked his driver to drive him to the top of a bridge we call Third Mainland Bridge. And he told the driver to park. and he jumped into the water. And that thing shook so many people. And shortly after that, we had so many people taking their lives by copycat suicide shortly after that. And it was something that shook all of us. And for us in the hospital, one of the first things that it brought to mind was the fact that we had been seeing on an average 1 case of attempted suicide per week on an average. And we were wondering, if we are one hospital and we're seeing that, what else is happening in Lagos? And it was based on that SERPIN as an organization was born. So our focus as SERPIN, sorry if you excuse me, I'm trying to send my slides. All right, so our focus as SERPIN is 1, 2017, we do mental health education and research, and we're available in all states within the country. And I'm going to talk a little more about our services. But before then, I'll just talk about mental health in Africa and why it needs attention. So we have a growing population in Africa. The World Economic Forum in 2023 said 60% of African population is below 25. In Nigeria, 60% of our population is below 30 years. And by 2025, there's an estimate that the youth population in Africa will be about 850 million. That's our 1 billion people. What that is it is both an opportunity and a crisis. An opportunity because we have the population to turn Africa around and make us a very productive, human capital, human resource. We have the ability. But also, if we do not address the rate at which we are growing and provide services that are required and build resilience for the young people, we would run into the problem. So it's both an opportunity and a crisis. And where this comes particularly into play when it comes to suicide is because globally suicide is rising. Across the world, suicide is the 3rd leading cause of death amongst the ages of 15 to 29. And I'm going to share some data with you shortly, so you will see the similarities with what WHO has said. And in Africa, if I go back to one of your first speakers, and we're talking about data, we don't have accurate data in Africa. We are not keeping correct data, and this has to do with a lot of things reflecting cultural taboos, religious beliefs, the stigma around suicide generally in Africa. And then we also don't have facilities. In Nigeria, I don't know about Ghana. In Nigeria, we're about 200 million, over 200 million people. We have 1 psychiatrist to 1 million people. So, and that's psychiatrists. I don't want to talk about clinical psychologists. I don't want to talk about psychiatric social workers, psychiatric nurses. So the reality is we do not have the capacity to deal with what is on ground. And what are the risk factors? Risk factors across board, mental health disorders. Studies have shown that with people who attempt suicide, people who have died by suicide, people with suicidal ideations, most of them have mental health disorders such as anxiety, depression, substance use disorder, bipolar disorders. There are also economic issues. The Prof from Cameroon alluded to the issues of unemployment, conflict in different places, the trauma and adverse life effects caused by conflict, displacement, and we are seeing that a lot in our region. In Nigeria, we have a high rate of kidnapping, internally displaced people caused by insurgency. So we are having a generation of young people who are growing up with trauma that is not being addressed. You have academic and educational pressures, and then you also have interpersonal pressures. One of the major interpersonal pressures or social factors that is rising in Africa is social media. The social media, it leads to cyberbullying. You think it's called social networking, but you're actually being isolated because you don't leave your house and you're in your system all day. But you lack the critical social skills to interface with people on a daily basis. So you're not developing the necessary skills required as a human being. to work with people. And then there's this issue of comparison, comparing yourself to so many people who put their best foot forward, who have taken 100 pictures before posting it online. But you are wondering, oh, why don't I look like that? Why don't I, do all of that? And with the age of AI, it's just getting worse. So that leads me to talking about what works in suicide prevention. We all know what works. And I mean, it's something that has been proven. We need to strengthen mental health access. We need to provide education and empower people. Improve crisis response. Those first three things are things that something that we are we work with, and our organization is channeled towards. The other things are we build protective environments whereby people are not afraid to speak about suicidal ideations. We need to reduce access to lethal means. I don't know about Ghana, I don't know about the rest of African countries, but in Nigeria, there are places you can walk into and buy poison off the shelf. I know that some people think it may be a bit dramatic, but it is. You can literally buy poison off the shelf because things for agricultural pesticides and all of that, you can buy it. It's not very regulated, even though it should be. So we need to reduce those things. We need to address the huge socioeconomic factors that plague us in Africa. And then we need to challenge the issue of stigma and silence. And now let me tie this back to our data in SOPIN. So when SOPIN started in 2017, we had this toll-free hotline. But sorry, it wasn't toll-free. It wasn't toll-free. And between 2017 and 2020, we received 251 calls. That was an average of 63 calls per year. So it wasn't toll-free. In 2022, we went toll-free. I'm sorry, that data should be March 2022, not 2023. We went toll-free. And since March 2023 to June 2025, we've had 1,825 calls, which has leapt by sixfold. We're now getting 379 calls per year. By the end of this year, I'm sure we would have doubled the numbers considerably, because as at the first quarter of the year, we had done over 250 calls. So the numbers will go up. And that shows this is post toll-free calls, once the lines went toll-free. Out of all our calls, 44%, about 45% were in crisis or urgent need, people who had suicidal ideations, people who wanted, they were in crisis, they needed to talk. 11 callers admitted to having previously attempted suicide. And we had 118 callers who were referred to mental health facilities physically, nearly just under 10%. Interestingly, nearly 75% of our callers fall between the age of 20 and 39 years. And that takes us back to the WHO statistics of suicide being the third largest causes of death for people between the ages of 59 and 29. So you can see the correlation there. Now, if you go on to the next slide, my next slide shows the age count for our callers. We have people that have called, we've had a 10-year-old call, we've had somebody who's above 60. But if you can see, about 47% of our callers were between the ages of 20 to 29 years. About 27% were between the ages of 30 and 39 years. Between people between the ages of 13 and 19, there wasn't a remarkable number of them calling. It makes us wonder whether what were the issues? Is it because they're still with their parents, that there's no free room, that privacy for them to be able to open up and speak? We're not sure, but like we said, research can go into all those kind of areas when it comes to access to the toll-free lines. The next thing is when you break it down by sex. When you break it down by sex, amazingly, most times when people talk about people calling the hotlines, people reaching out and asking for help, usually you find that traditionally it is women that do that, what data has shown. But our hotline shows that we've had 737 females, but largely we have nearly 1,000 males have called. Over, nearly 1,000 males have called. What that is telling us is that the men are reaching out. And why are they reaching out? Traditionally, we don't think men talk or men reach out to help. So what is going on? What is it? And one of the things we need to ask is it the fact that the phone lines are anonymous? You don't know them, you don't have access to them, or you can't see them face to face. Is that why it's been easy for them to make these phone calls? So that is a question that's still open. And I know, like one of the speakers has said before, all these areas are still open for research, and those are things that feed policy as to how do we approach suicide prevention in our communities. So if you look at the stressors, similar to most studies, the people that call the most have a history of behavioral, mental health issues, and we've seen depression, anxiety, substance use disorders amongst them. Various other issues include domestic violence, that's the second largest group, domestic violence and other issues. Then you have financial and health issues, nearly, struggling for a position there. They're nearly the equal, but it's a major thing we're seeing, a trend we're seeing. Academic issues and relationship issues also fall within those. So there's nothing that is leaping out at us from the data we're seeing that is different from what is going on globally around the world, what young people are struggling with around the world. It is a general problem around the world. So what are the key insights for us that this data is presenting for us? What are the key insights? First, youths are calling because it's anonymous. Before 2022, it was, you had to, we had calls coming in and quite a number of young people. But, obviously, subsequently after 22, when it was toll-free, it skyrocketed. And you can see that majority of our callers are young people. One of the complaints is that they have no way to access mental health care. Even if they want help, who do they ask? Where do they go to? They don't know who to speak to. And we've had to make several referrals for face-to-face counseling, even though quite a number of them prefer the phone counseling. And it's when we feel it's when we speak with them and they agree that we do the referral to a physical facility. Some of them have access to mental health, not mental health. Some of them have access to counseling and therapy. But we've heard that a lot of issues, when it comes to mental health is not addressed when the counseling is provided. They talk about relationship issues, talk about relationship with their parents, but nothing to deal with when somebody says, I am struggling with suicidal ideations. There's nothing, nobody addresses that. I feel that, I'm hearing voices. They go into the spiritual realm. A lot of times we've heard that from our callers. More males have reached out to us. Why? I asked that question. I wish I can answer, but I don't know. Then suicide-related calls show urgency, not just worry. Yes, a lot of people are worried when they feel they have suicidal ideations. But one of the things we've realized is that because they're worried, they call and they want that quick interface. They need someone to talk to. And usually we found that majority of them, we've been able to de-escalate the situation. We've been able to de-escalate. Some of them come in, call back for further counseling. Some, are referred to physical facilities. Some are referred to therapists online, other therapists online, because they seem to prefer online sessions. So it shows that there's an urgency to connect with people, to talk, to help them, to walk them through whatever they're going through at that point in time. And lastly, a lot of young people have called, but they have a lot of barriers. And one of the barriers you can see we've talked about is the toll-free access. But then also, do we have youth-friendly facilities for them to access? When they go to a clinic, do people attend to them based on the problems they bring individually as young people? Sorry.
All right.
So what are the implications for policy and practice? I think the implications are very simple. There's a need for youth centers, culturally aware suicide prevention strategies, very important. We need to equip our schools and university staff with basic mental health skills. A lot of students start manifesting, a lot of young people start manifesting in schools. We need the teachers, the school staff to recognize the symptoms, know what to look for. And once they recognize the symptoms, know what to look for, they will know whether to refer or whether, if they have the basic mental health first responder training, can they provide some level of counseling on that level to help with the students? We need to look at critical roles of helplines. As you can see from evidence of our own helpline, that we may not have the physical staff on ground to provide one-on-one mental health services, but people can call in to receive those things. And situations are de-escalated, they can be referred, and counseling can continue online. Like I said, toll-free helplines are lifelines. They're affordable, especially if they're toll-free. And it's important that it's also accessible. One of the things we're talking about is language. We have so many languages in Nigeria. How do we provide it for people in languages that they understand beyond English? So what are we hearing from the helpline? I want to close on the voices we're hearing. What are the voices we're hearing? These are things that people have told us. The first caller, he had a blog while in university, did quite well academically. So expectations were very high when he graduated, but he has not met any of them. This was one of our callers said, and that is something he's struggling with. Another person said he was seeing a therapist, but he wasn't happy with the quality of care that he was receiving from the therapist, and he had nowhere else to go. So he dropped out from therapy and hasn't seen anybody. Another person was diagnosed with, it's supposed to be bipolar disorder. I'm sorry, not borderline personality disorder. In his university days, he was struggling with forming attachments, especially with women. And his current girlfriend is unaware of the fact that he has a mental health condition. He hasn't been able to tell her, and he doesn't know how to tell her because he doesn't know how she'll react. And lastly, the caller says she's scared because she's having auditory hallucinations. She's hearing voices, and the voices are telling her negative things about herself, which she feels that she'll soon start believing. And she feels that she has become a burden to her brother because her brother is the one caring for her, providing care, providing the money for her to seek care. Those are the voices we hear, ladies and gentlemen. Those are the voices we hear from young people. So the truth is, young people are reaching out, but do we hear them? Do we understand what they're saying? It's important that we must meet them where they are. We need to be able to position ourselves where they can reach us. And it is very important for us, if we do not have the manpower to provide psychologists, social workers, psychiatrists, in every hospital, in every village, in every crook and cranny, we can invest in helplines. We can invest in training people and invest in community awareness. And all of this, ladies and gentlemen, will help to save more than one life. And one life saved is not a little. Thank you very much.
Thank you so much, Ms. Tadi. Thank you so much. Indeed, these are rich insights we need to learn a lot of lessons from. In fact, I'll come back to you on a few things that I saw, which I would want further clarification. But we have two other panel members here who
I'm
also
sorry,
want to
I can't hear you any longer.
Hello. Hello, can you hear me? Hello, Ms. Tadi.
I'm sorry, I can't hear you. You're muted.
Hello, Ms. Tadi.
Okay, I can hear you now.
Yes.
I can hear you now.
So I was commending you for the presentation, and I was saying that there are a few insights we have seen which I would like further clarification on by way of questions. But before I do that, there are two panel members here who also would like to throw some light on youth suicide. So I'll go to Professor Kwashi. In fact, you have done an extensive study, with this demographic group. You have done even a systematic review on all that. Maybe you can also throw some light. What are the key risk factors you are also seeing from your own research and that of your systematic reviews in Africa? And again, let me also tie it to what Mr. said. I also know that you are wearing the hat as the president of Ghana Association of Suicide Prevention. Has there been any effort, towards meeting the needs of the youth from your association? So tie the two for us. By way of your response.
Thank you very much. And let me say a big thank you to Mr. Day for that initial presentation. It was very insightful. And for me, it's a good reflection of what is happening and the good efforts you and your team are putting together in neighboring Nigeria. So let me start from the second bit. We are in collaboration with, and I mean the Association for Suicide Prevention Ghana. It's in collaboration with other local and international NGOs with similar interests of suicide prevention, not just in Ghana, but across the world, and trying to gather support so that we can also get a toll-free line running. Hopefully, this will help us with real-time data from particularly young people and the aged. So we will know which direction to go in terms of providing practical, real-time help. I don't know about the other bit of that same question because I believe that for us to make a headway, we need strong political will from the top. Because when you look at the issues, for example, the evidence that, or the strands of evidence that Ms. Study has just shared, if you want to put them in perspective, you notice that there are huge macro-level problems that if government is able to step in boldly, we can be making some significant headways. So, for example, in our context, we have been told that education is the key. And this I tell my class all the time. This is the message we are exposed to right from the beginning in primary school. So for you, you have hope because you are in school. You finish school, you have your certificate, and you believe that there's a good future for you. Now, you finish school, you have the certificate which represents the key, only for you to realize that the lock has been changed. And what does that mean? You have the certificate, you have CV, you go out there, you get or flip through the newspapers and they say they want somebody with a first degree or whatever certificate, but they want 3 years work experience. Where do you get that? Mm-hmm. And so you are frustrated. Already family has invested so much to see you through school, hoping that you come back to pay back, and nothing is happening. But let me quickly jump onto for me, an important point we all need to be aware of. Prior to COVID, it used to be what is called the 2 C's. The 2 C's representing C as in the letter C, ABC. It used to be the issue about climate change and then conflict. As you speak, 2 more have been added, so making it the 4 C's. The first now, COVID and its aftermath effect. The next is climate change. The next is cost of living. And finally, we have conflict. I can imagine that nearly 90 or 95% of the evidence that Ms. Study has shared could be placed into these 4 C's. So we have a lot of young people who are still living with the aftermath of COVID. They lost significant others who were the breadwinners of their families. They have significant others who are now down with, physical disability due to COVID. And so the years lived with disability have now increased, and family members, the relationship has now changed. Young people have now become parents, and parents have now become dependent on their young people when they have to take care of them. You look at climate change, and the evidence is clear. We have quite a number of young people who are moving into agric, but our agricultural system largely is, heavily dependent on what nature brings in terms of rains. And if you don't have the rains, it means that you have problem with, meeting the requests and demands of your creditors and so on. And so I have seen a lot of young people losing their farms and crops and so on because of the lack of rains, or flooding that wipes off everything. And so there is some kind of hopelessness. As for conflict and the issue about cost of living, I believe that they are clear. As we speak, in our own backyard, Boko, it is clear in the media now that government is considering evacuating students from that part of Ghana. And it's as though nothing is happening. You don't hear anything among, I don't know, I may be wrong, among mental health researchers. How are we considering this? What are the implications? This started long ago. And I don't know if we are waiting until it gets out of proportion before we step in and to start doing our risk factor research, and the conflict led to this and that, And so these, for me, the 4 C's are very critical, and we need to consider how we are contributing evidence, particularly to help young people, come out of these states of desperation, hopelessness, and so on. One last thing I'd like to say about this, before I hand over the mic to my colleague, is in our public mental health research, let's be careful to include those who we normally underrepresent or completely ignore. Typically, when it comes to young people, we focus by default on the schools. But we know this is Africa. Not all our young people are in the classrooms. Quite a number of them we have, now called NEET, N-E-E-T, not in education, employment, or training. We tend to ignore them. They are homeless. Some of them are homeless. Some of them have dropped out of school. Some of them are on their own. We have teen fathers and teen mothers who themselves require parental support and supervision, yet they have become parents. And these are young people who cannot be found in the classroom, and we often ignore them, and we go into the classrooms, and everything we do, it appears the evidence is more about those in classroom, but not those outside of it. And so I think there's a lot we have to do in terms of research, but also how we can keep our advocacy going, trying to convince and engage with government and the relevant government agencies to help with, real intervention. Let's government make some investment, inject some efforts in that space so that we can bring back hope to our young people for the future. Thank you.
Thank you so much, Prof. In fact, the picture you have painted shows clearly that we need a lot of governmental efforts, political will, to tackle, these 4 C's you are talking about. And that is where the issue of collaboration will have to come in, so that advocacy can also be scaled up to get government attention on this. Mrs. Boakye, the last time I found out you were working on, is it university students?
Yes, please.
What have you also found, and what is your study also directing us to? Yeah.
Okay, so basically, looking at university students, I'm actually looking at gatekeepers, and these gatekeepers more has to do with student leaders. Looking at the evidence and looking at the literature, we realize that when it comes to evidence-based interventions, we have the universal, we have the selected, and then we have the indicative. And the universal is population-wide. The selected is more tuned towards gatekeepers, training them so they follow up on people who are at elevated risks. So focusing on gatekeepers, when we look at universities or campus-based interventions, the one that's most common and effective is gatekeeper training or education. These studies are coming largely from outside the Western countries. To the best of my knowledge, we don't have some here in Africa. We don't have any of these studies here. But the evidence and findings from these studies are showing that gatekeeper training is that effective. But then when you look at gatekeeper training, you realize that the gatekeepers that they are most at times focusing on have to do with teachers or lecturers or mental health professionals. At the same time, when you look at young people, looking at their help-seeking behaviors, the evidence is showing that they normally would prefer confiding in informal sources, that is their friends and family. But then the study is showing that focus is on teachers, as gatekeepers and then mental health professionals. And these young people would rather want to confide in these informal sources as compared to going out to confide in mental health professionals. So that led me to focus on student leaders. And findings from what I'm doing, my study, is showing that indeed, even interacting, it's a mixed method study. So at the qualitative phase, interacting with student leaders, they indeed tell you that young people would quickly run to their fellow peers, their peers, and they would confide in them. And if that is the case, then why not focus on equipping and training peers or fellow students just like student leaders? Why would I focus on student leaders? Student leaders, because they are key. They stand out as leaders. So normally, most university students would want to reach out to them because they realize they have that note and they have that kind of attachment to resources. They're able to lead them on. Interacting with student leaders, I get that feedback that they've had some kind of suicide education. They've had some kind of trainings. And these trainings have informed them about suicidal signs, informed them about referring their peers to the career and counseling centers. So if this is the case, then when we equip student leaders or we equip young gatekeepers, it would help to give them access, and they would be able to identify their peers who are prone to suicide or at risk of suicidal behaviors, and they can then refer them on to mental health professionals. And this will help with timely intervention and treatment and management for that matter. So I think we should, looking at the evidence and the studies I'm looking at, if we can focus on the help-seeking behaviors of young people, they normally won't run straight to counselors or mental health professionals. They normally would confide in their peers. So if we can equip their peers, it would help them, connect them then to counselors. So
wow. So what is existing is that we are seeing a lot of investment being made in training the teachers and all that. Meanwhile, the students don't go to them. They rather will prefer going to their colleagues, student leaders. So as she said, why don't you rather invest money in training them, just so they can be there to help there? I think that is a finding that the whole world would like to read, because we have neglected, that section, of gatekeeping for a very long time. Very commendable work you're doing. But Mr. Are you still there?
Yes, I am.
Yes, please. So there's a question here. We heard from your presentation that indeed the youth are reporting, all right, or they are calling, your toll-free lines a lot. But what about the elderly or the older persons? Are there no issues with the older persons in Nigeria?
Okay, thank you very much. If you see my slides, you would have noticed that I also have data for people over 40, and we have some data for people over 60. We don't have as many calls. As you can see, the rest of the population make up less than, maybe roughly about 25% of our callers. So, it might be the fact that, one, we don't advertise. It's usually word of mouth for the hotline. So the young people are the ones most likely to probably share via social media, our numbers and all of that. Older people may not be aware of the fact that the hotline is available. Part of it is also due to funding. The toll-free hotline, the toll-free lines are being paid for. They're being paid for by us personally. We don't have funding for that. So, we'd rather pull our funding towards keeping the lines open than advertising. You understand?
I see.
Those are things that we need to sort of balance out. I am sure that if we do more publicity, the number of calls would increase, and also the age range of people calling would also increase. Yeah, I hope that has answered the question.
Maybe you can also look at the language. For these older persons may want to speak their own language, all right, when they call. But if there are such services there, then they're likely to call. But the next question, we also want to find out really what is the level of collaboration you have had with other stakeholders in this suicide business. You know, psychiatrists, governments, and others. Is it purely a private, work you are doing with SUP-IN, or you have some collaboration, with other stakeholders, with SUP-IN and your work?
Okay, thank you very much. So I work with the federal government hospital, teaching hospital, and SUP-IN started out of that federal government teaching hospital. The hospital funded it for the first 2 years, but we sort of grew out of the hospital because we needed to be able to refer people to different states within the country. And, the hospital, it wasn't going to be able to continue funding it, which is why we now became an NGO. So presently, we have over 100 members from over 55 institutions across the country, all mostly government hospitals, but we also have them in private facilities. And what we do is, once we get a call and we need to refer somebody to a physical location, we will tap into our own network and refer that person to the healthcare, mental health professional, so that that person is able to provide the service. And if they're not, they're able to say, come in and see a colleague or do this. And all our collaborators have agreed to do the first assessment. The first visit is free. Subsequent visit, they may have to pay because we don't have the funding for that. But all first assessments is free from all our partners and collaborators. We've also tried to get private organizations on board, but it has been a struggle. And part of that is the issue of stigma. I still had someone telling me last week that, as a corporate body, sponsoring mental health or suicide prevention, it just looks a bit funny. It looks a bit weird. It's not a normal thing. So those are some of the struggles we have.
I see.
In the past year, we've been working on decriminalizing suicide in Nigeria. Nigeria has come out with a mental health bill similar to Ghana. We adopted the UK mental health bill. So in the last 2-3 years, the bill has been repealed, and we have a new mental health bill. We're working now on a bill, on a law to decriminalize suicide in the country. The reason I'm saying this is we're hoping that that will capture some certain collaborations with the government, where the government may be able to fund some of these things. We're hoping. Like we all know, hoping is one thing, the reality is another. But we also work with, for example, I'm here today, Professor Osafo, Partners for Life, and we look to collaborating with other organizations out there to learn from them and see how we can adapt some of the things to work with us here in Nigeria.
Thank you so much. Certainly, there's a lot to learn from Ghana as well. We achieved our repeal of the suicide laws not without struggle. So we are ready to share quite a lot of insight on how you can also get there. Gradually, we shall get there. All right. So maybe at this stage, because of time, I would like you to give us maybe your final words, all of you, on youth suicide. What is the way forward? Starting from you, Ms. Tadi.
Okay, thank you very much. The reality is we have a lot of work to do when it comes to youth suicide prevention. The world is now, we've always said the world is a global village. Back in the days, you used to say the world is a global village, but the world is literally really a global village now because of social media. With suicide, we talk about copycat suicides. In the past, it would have to be somebody within your physical location who would take their lives by suicide that you would see copycats. Now, somebody in America or a village in China who self-immolates, and and because somebody took a video and posted it online, it will trigger so many other people. So we need to, we need, in the age of social media, we need to start looking at innovative ways of addressing young people. Like the Prof said, we focus on a lot of students who are in school because it's easier, honestly. Working or with out-of-school youth, we need to look at ways of addressing them. Is social media a tool that we can use? That's one of the things we can look at because everybody has a phone these days. Everybody has a smartphone. no matter what, it can play something. Is this something we need to look at? How do we move from just helplines that are voice to text services, you know, for people who can read? And talking of people who can read, do we even serve the vulnerable, like people who have disabilities, who have visual impairment, hearing impairment? I don't think we've even touched those areas. So there is such a lot to do. We can only keep, because if we don't, before we can address the vulnerable population, we have to address the general population. Unfortunately, and that trickle-down effect will slowly go into all the other sections of the community, and that's the reality of it. We need to look at it from a large scale and then trickle downwards. I'm happy to be here on this platform, and I'm hoping this is one of the platforms that we'll use across West Africa and Africa. Thank you.
Thank you so much, Ms. Tade. It's been a great, session with you, and we have learned a lot from you, and we are also prepared to want to work with you, just so we can give meaning to this effort. Thank you so much. Shall we give her another round of applause for a beautiful presentation? Ms. Boakye, yes, we have also heard something very, very exciting coming from you and your research. What is the way forward, given the insight you have gained so far?
Thank you. I think with what I've shared, and even with what Ms. Tade shared, some things I picked up from her, which I think emphasize the need for peer gatekeepers or young gatekeepers. She spoke about limited access to mental health professionals, where the people who call in or young people who call in are looking at urgent help. She also spoke about youth-friendly strategies. And then she also said, meet them where they are. So to meet them where they are, to have youth-friendly strategies, we should look at empowering and equipping, training young people who can support their peers. I think that looks like an immediate help for them.
Wow.
Thank you.
Something along the lines of tax sharing or tax shifting.
Yes.
Yeah. Certainly, in a context where we have limited human resource in the mental health sector, we certainly need to reach out to people we can easily fall on to help. So I think this is a very worthy recommendation for us. Prof.
Thank you very much, Johnny. So I have three things to say quickly, but before them, let me say that suicide is preventable, and the prevention of suicide is everybody's business. You don't need to be a suicidologist like any of us sitting up here or those of us among you. Sometimes merely listening is enough to get somebody out of their emotional or suicidal crisis. And so let's master the art of empathic listening. That can help a lot. My first point I want to make is just to draw your mind quickly on something about the emphasis we keep laying on collaboration. Suicide, any effort towards its prevention must be collaborative, because we still don't fully understand it yet. But when it comes to suicide research, and because this is largely an academic exercise, I like to focus more on the research aspect. Some academics or researchers tend to think that, suicide is just one of those mental health outcomes. Let's just go in there. They gather data and then they just write reports, submit to a journal. And these days you don't have very refined academics having the time to review papers anymore. And so you have very good journals churning out papers that are substandard. And for us in the area of suicide prevention, this is troubling, because if inappropriate content finds its way into academic outlets, we'll have problems. So the WHO has standard for reporting suicide in the media to guide media professionals. Now, some academics have managed to craft one for academics. And so you do your suicide research, and there's a way you have to report it. There are some things you don't say in the report. For example, you don't say someone committed suicide in a context like Ghana, because it is no more a crime. So that C word does not apply. Now, in the last 2 or 3 years, in fact, just about a few weeks ago, I had the same problem with a very respected journal, and I have to mention the name, BMC Psychiatry. I got an alert. I have subscribed to their weekly alerts, and this paper came in prepared from Ghana. Fine data, qualitative data. I went in there, I cringed, and I got upset. In their results section, they have reported the finer details of the methods that the people used. The DDT they used, the methods they used, where they hung themselves, the kind of medication or toxic substance they ingested. When journalists do this, we complain. And you have a whole respected journal like BMC Psychiatry putting this out there. Immediately, I wrote a rebuttal to the journal. Please invite the, authors to make revisions because this is wrong. After nearly 2 months, without hearing from them, I wrote back 2 other, prompts requesting for their feedback. After nearly 2 months, the senior editor got back and said, they have already alerted the authors to make the correction, so my rebuttal was not necessary. It wasn't, I think I'm using the wrong word, rebuttal, like a prompt, And so whatever I wrote was not necessary. Unfortunately for them, I know the authors, at least one of them. So I contacted him, and then he got me the exact email that came from BMC Psychiatry. And in that email, BMC Psychiatry had mentioned that they had gotten a prompt from a reader of their journal and someone who has also been publishing in their journal that these parts will have to be corrected. And it must be consistent with the standards provided by the WHO. Now, they wanted not to have my, correspondence linked to the paper published because then it will be a punch to their, or a dent to their image. I don't have a problem with that. But look, if you go back to see that paper, the corrections they have done all my life, I've never seen one before. It's like rewriting the whole paper again. But the sad thing is that the bad version is still out there in the public.
This deserves applause. This deserves applause, honestly.
I can imagine you are asking, how is this connected to youth suicide? We know that young people who may be going through emotional or suicidal crisis may not have the idea in terms of the exact method to use to end their lives. But reading from a scientific source like this gives them the idea. And so please, I have had a very bad experience with some colleagues in this university where they have published a paper on suicide, and I alerted them that, look, I just saw this paper you published. This and that, these parts are not right. Could you go back and make the corrections? And it became hell between us. And it has, actually brought a rift in our academic relationship. If you know someone who is into suicide research, please, when you put together your data or manuscript, it's only nice that, peer feedback, send the manuscript to them, let them have a look. We are all here. We'll make time to do this. We don't want our name to be on your paper. That's not the drive. You want us to just strengthen the paper. We would do that, particularly for people who, there are people who are publishing to get promoted. That's fine, good motivation, but make sure that the content is good, because in this world now, whatever you put out there will be there forever, because the internet will not forget. My second point is, let's try to engage more in our research persons with lived and living experiences. This is a whole wave now around the world, and in particularly the space of mental health research. And it is very relevant also in the area of suicide research. Because look, the person who died by suicide has the real reasons. We don't know. And so if somebody has attempted it or has survived it, perhaps they have the answers. So let's engage them more in our research and other advocacy programs. The final bit is with funding. In fact, if you are an academic or a burgeoning academic and your focus is to get funding in this space of suicide research, particularly in our context, please be measured in your expectations. One, not too many funding bodies are ready to fund suicide, and generally mental health research. Well, mental health generally is, attracting a lot, but suicide specifically, we don't know why. Not too much funding, and when the funding is there, the conditions are so strict. I remember we got some small funding, $20,000 funding, and the funder says they cannot support honorarium or they cannot support salaries for the investigators, and if we agree to, budget for honorarium, it shouldn't go beyond $1,000. Yet this is fairly huge work you need to commit meaningful time to and do. So please have measured expectations when you are coming into this space. The funding is not too abundant, but of course, if you work hard and you have the right collaborations with big boys and girls in the space, particularly outside of our context, you are likely to make more expansive research, engage more with the system and the global space of suicide prevention. And with time, I believe the money will come. Thank you very much.
With time, the cash, the money will come. Let us not give up. It is not an easy field, but for me, it is commitment, because you're going to suffer a lot of challenges, but once you commit yourself to wanting to change something that is really taking precious lives out, one needs to open his heart or her heart and commit to it. Friends, if there is nothing at all we have learned today, I was really listening to Prof a lot while speaking. Died by suicide. I never heard commit until he made a reference to it. So it means that people who are committed to changing the narrative on suicide, we also need to tone down on the word commit, because when we say commit suicide, then we are saying that it is still a crime, and therefore we need to still stigmatize it, right? So thank you so much, our August panel members. It's been a so rich session. I believe a lot has been learned, and certainly we shall fall on you at another time. Thank you so much for your time. Friends, let's give it to them. Let's give them an applause. Let's show appreciation. But then again, I still want to crave the indulgence of the director. The program, we're supposed to have Q&A after each session. Time is fast running, and there are a lot of programs ahead. So why don't we take the last panel quickly? Yes. On mental health, suicide amongst older persons in Africa. Why don't we take it quickly, and then we can ask general questions for all the panel members who have been here. All right, so to do that, let me call Ms. Priscilla Osebonsu. Priscilla, kindly take your seats. You are no longer the technical person. You are now a panel member for this session. And then Mr. Eric Nantie. Mr. Eric Nantie. And then we have Dr. John Bosco Chika Chukwuoji. Dr. John Bosco Chika Chukwuoji. Yeah, Prof, we shall have you briefly. Yes. All right. Dr. John Bosco, are you here? Are you with us?
Yes, I am.
Wonderful, wonderful. So we are going to look at the mental health and suicide among the older persons in Africa. But before I go ahead and then take your remarks, let me just say something briefly. When I was a child, I had this grandmother, in a house. At some point, I remember, she was like, give me injection so that I can die. Give me injection so I can die. I never understood it until, I came into this whole suicide research area. What is the issue about older persons and suicide? After having lived your life and, having had children, having had grandchildren, and virtually expecting your maker to call you, why must you entertain the thought of wanting to kill yourself? Any remarks you want to share on that?
Okay, thank you so much. That's one of the first things I wanted to say, that the conversation on suicide among the elderly, it's because we've talked about youth suicide, how young people, it's known in literature that there are increased risks, risky behaviors, etc. And there's increased risks also with the elderly because of the stage. So in our slides, we may show just a bit of it. We made it clear that suicide can occur at any point in life. That's one of the things we want to let you know, that suicide can occur at any point in life. But for older folks or older persons, because of the vulnerability that comes with the age they are in, so physical, ailments, mental health, etc., all of these things affect their mental health. So we'll expand and go deeper into that. So mental health, depression, and even chronic conditions, you know. So all of these things affect them, and they're like, okay, I've been here for 60, 70, 80 years. I've seen some of my grandchildren. I think it's okay for me to go now. Yeah.
Wow. I mean, until recently, I never heard about suicide in the older population. You hardly hear it. You normally hear that of children, young people, and the youth, early adults. But an older person killing himself. Mr. Nanche, any remark on that? Per your studies, yes.
You know, like she said, suicide is not age dependent. And I think our previous two panelists have already spoken about when they showed their statistics. It's higher among younger people, so 20 to 39, around that age group, and then older adults as well. You can just ask yourself the question, why don't we want to grow old? Like when you talk about aging, people are so reluctant to even consider it or talk about it. So just the fact that you may seem to have a negative attitude towards it should tell you how those there are feeling in the first place. So like Priscilla has mentioned, there are so many issues around the aging process, and so it makes it quite a challenging period for those there.
Wow. There's a lot to learn from this. But Mr. John Bosco, Mr. Chukwoji, are you there?
Yes, I am.
Very well. Please, can you also share some insight for us on this nexus between suicide and aging?
Okay, so I have prepared a slide which I could share and then just speak to it briefly.
Sure.
If that is.
That's fine.
Okay, thank you.
Yeah, maybe you can go ahead. Yeah.
Okay, so I'm happy to be here and thank you for inviting me. The aspect I want to come from is the area of advancing the psychosocial interventions for self-harm and suicide behavior in African older adults. And the big question in suicide prevention is about knowing who is at risk. That is the first big question. Then the second big question is when these people are at risk. And the third big question is how to help these people when they are at risk. A huge part of one of the major barriers to preventing suicide is that much of the time, the emphasis on suicide prevention is on those who are at high risk. When individuals are at low risk or that they are not showing warning signs, if we put it that way, they are often ignored. And so in health system-based suicide prevention, it is individuals that have been assessed and identified at risk, but that are always the targets of interventions. But there are times when people do not show those risks and they still go on to take their lives, including older adults, and it becomes more prevalent when you look at this from the perspective of older adults. The African reality of the suicide is that we do not really have age-specific and culturally appropriate mental health services in very large numbers. And the other issues we've talked about, including mental health illiteracy, limited access to mental health professionals, and even when you now talk of geriatric health services, it becomes more challenging. Stigma is there, and we have not integrated mental health interventions into national aging policies. And when we narrow it down to Africa, we understand that older adults in Africa, they experience some unique stressors that are not what we find in very developed countries, including the issue of welfare systems for aging and the pension system that is often very unpredictable. And then we also encounter this issue of limited research on effectiveness of programs in Africa. When you look at effective interventions generally that have been found for suicide, there could be targeted interventions that, as I earlier pointed out, just focus on at-risk populations. The indicated interventions address mild symptoms, and crisis interventions usually work for those that have had past suicide attempts. But in going further, community level and policy level interventions are those areas where almost every one of us becomes involved, becomes important. And community level interventions like public awareness, which is part of what we are currently doing, limiting access to lethal means, and then interacting with the media for responsible reporting of suicide. And I'm glad that we are coming from a background of a discussion regarding that. For policy, we talk of advocacy, multi-sectoral collaborations, and capacity building programs. The existing suicide prevention programs for older adults, the United States Department for Health and Human Services categorize these in terms of the setting where they occur. Do they occur in provider offices, in emergency departments, at home, or online? And online interventions become important because of a recent study that I just read last week that shows that older adults who engage more in social media have better mental health services. And that becomes more of like something that is contrary to what, if we agree with Ms. Tade's earlier presentation, that the adolescents have worse mental health outcomes when they have social media engagement. So, but the recent meta-analysis, the most recent meta-analysis on effective interventions for suicide in older adults is as old as 2017 by Okolie et al. One other more recent one was in 2022, and that particular one was on pharmacotherapy for suicide prevention, where it was found not to be very effective for suicide prevention. But this one for 2017 is the most comprehensive. And the findings show that effective interventions for suicide prevention are usually multifaceted, primary care-based depression screening and management programs, and treatment interventions combining pharmacotherapy and psychotherapy, telephone counseling for older adults, and then community-based programs that integrate gatekeeper training, depression screening, group activities, and referrals to treatment. When you look at specific interventions, one intervention that have been found to be effective for suicide prevention is the safety planning intervention. So the safety planning intervention was developed by Stanley and Brown, and it's been adapted for different settings, which is why I find it very useful for older adults. One area where we've adopted it in a program that I'm currently working on is on suicide prevention for justice-involved individuals. The key aspects of it includes looking at warning signs for suicide that may be developing, and then finding the specific things, activities, or places that are likely to destroy individuals, and then what people can do to destroy themselves. Also, letting them identify those that they can discuss their distress with, including professional consultation, providing them with emergency contacts, a plan to reduce access to lethal means, and also helping them to identify reasons for living. The second one is lethal means counseling, and it's just about trying to help the individual remove or limit the access to which they have things they can use to harm themselves, and then also letting them know generally what they can do to create a safe environment. The rationale behind this is that people usually are inflexible when it comes to suicide. Well, when people have decided to take their lives by a particular means, it's not easy in that short moment to decide to use other means. So if, for example, an individual has decided to use organophosphate for suicide, and the particular mean is unavailable, it's not easy to switch to maybe gun, to take their life by gun, by shooting themselves. Then the third one is crisis response planning. And in crisis response planning, there are 5 major aspects, which is identifying the warning signs for suicide, helping them to develop strategies for self-management, helping them identify reasons for living, providing them with access to social support and crisis or emergency lines. When we look at African older adults, how do we ensure that we have culturally responsive interventions for African older adults? First, we need to train our health workers in suicide risk screening. When we train them in that suicide risk screening, we also need to go for that to be able to arm them with certain basic skills that will enable them to intervene. People don't always do screening in healthcare systems because if you find a problem and you don't know what to do, you run into the problem of moral distress. So it's better not to find that problem, and so people stay away from it. We also need to work with faith-based organizations like churches and mosques, and this becomes important for older adults because they are usually religious in an African setting. Psychoeducation is important for families and caregivers, and then gatekeeper training for community leaders and traditional healers. And then finally, we also must incorporate local idioms of distress and African ethos into our assessments for suicide and our treatment for suicide. So to center older adults in suicide research, care, and policy in Africa, it is important that we assess the effectiveness of current suicide interventions specifically for older adults. And I'm going to be proposing that we need to convene a technical expert panel that will identify these existing interventions in Africa and then work towards developing a culture-fair assessment of suicide for Africa. As clinicians, we must continuously work towards capacity development and having system-wide screening and integrating mental health into chronic illness for older adults like diabetes and stroke. We also need to develop protocols and leverage community connections. For policymakers, it is important that they include suicide prevention for older adults in their national health plan. For example, I looked at the Nigerian Suicide Prevention Strategy Framework, which was published in 2023, and it was talking about one of the areas of emphasis is on interventions that work across all populations. There was no specificity when it comes to suicide prevention. The experience that informed this presentation for me is from my work at the National Center for Health and Justice Integration for Suicide Prevention, which is funded by the National Institutes for Health in the US. It's the beauty of it is the collaboration that cuts across both people in the academia, both people that are working in the justice system and people that are also in nonprofit organizations. A key aspect of what we are using in this program is what is called caring contacts. In caring contacts, by the way, the general goal of this project is to identify people who are involved with the justice system, who are at risk for suicide, and connect them to care. Within the short time of release from jail, people are usually most at risk. But if there is a way to connect them to care, you help to reduce suicide. So in caring contacts, you look out for the individual to let them know that you are thinking about them and let them know that they have the resources available to them and they should be able to reach out. So it's more of like sending a message or sending a letter to them where they are and expressing caring that you are willing to help them. So my final call to action is that we should prioritize age-specific suicide prevention trials in Africa, adapt evidence-based interventions with cultural relevance, and create enabling frameworks for community mental health delivery if we are to serve the needs of older adults. Thank you.
Thank you so much. Thank you so much. This is a clarion call. Thank you so much. A clarion call for us to develop age-specific right, Doc, maybe you may have to help us have your PowerPoint slide. Yeah. Yeah, so you are making a clarion call for us to have 8 specific suicide interventions, all right? And I think that is a very good call. But may I find out from you, Mr. Nante and Priscilla, so in Ghana, what are the context-specific risk factors for suicide among the aged?
Right. I'll start with something he said about policy. And sometimes I don't think it's just about making policy, maybe making policies for that. That's also important. But also other economic policies that governments put in place. I always give the example of the haircuts that happened. And I always give the example because I personally saw a lot of people coming to my clinic. I practice as a psychologist as well. They come, and then some of them have suicidal ideations because of what happened, because a lot of them had their pensions being stuck somewhere. And then you have no idea when the government is going to release the money that you've worked for all your life. So that is a risk factor. Even though we are talking about policies, this is a different kind of policy that I wonder if the finance minister at the time thought about the mental health implications of that particular haircut that they decided to do. And then the specific risk factors. So I'll slide a lot. This time is gone. But I'm going to focus on 4 case studies that I have here. One will be of a 60-year-old man who killed himself and his wife over allegations of infidelity. Now, this happens across board. It's not just a young person's issue. Older adults are worried about infidelity as well, yes. And then there's also someone who shot himself because of creditor issues. So someone in debt, so financial issues. There's also a case of a 65-year-old woman who jumped to her death, again after financial issues. And then another 62-year-old person who left a note saying he was just tired of life. As you can see, these issues in themselves are not peculiar to the elderly. Everybody can experience that, but the elderly are also people that we should consider. Because I've realized that when it comes to mental health outcomes, we rarely consider older adults. It's as if we should know that they've lived life enough to be able to handle their own challenges. Yeah, so in talking about mental health among the elderly, it's something that we should almost consider them as young people as well. The same challenges that the younger person has, the older person is likely to have that as well.
I see. Very interesting. But Priscilla, how would I know that an older person is having a suicidal thought?
Okay. I just wanted to add one thing I saw in a paper by Edinkwa, and he mentioned sexual dysfunction. And
sexual dysfunction?
Yes.
Older person?
Yes.
Hey.
Sexual dysfunction.
My age is a stigma. Oh, it's an interesting finding that I want to hear more about.
Yeah, so that's one of the main things, and I'm saying that because I wanted to bring it up because the literature shows that men have higher, rates of suicide or attempt ideation as compared to women. And we know that in our parts of the world, sexual performance for the men is a big issue. So for older adults as well. And in our slides, we have a case here. The 67-year-old man cited shrinking penis and his wife's affair from the paper. So it's one of the things that I just wanted to mention. So if you have an older person at home, don't think that, you're a grandpa, you should be thinking about your grandchildren. They think about all of these things as well. Yes. And so for you to know that an older person, having suicidal thoughts or thinking about suicide, one of the things, depression. Depression is very high among older people. So it's one of the things that we found as, a warning sign for you to know that older people, this person is suicidal. So depression is one of the main things. And then being alone, social isolation. So I think just this morning, I was reading on social media, and the lady was talking about the fact that her father's best friend was buried over the weekend. And her father is being buried in September. Then the last of their trio, I think their 3 best friends, called her and said, "I come in Kwao." And then I was like, okay, this is really, in line with what we are going to talk about today. That I come in Kwao statement to wait is left with just me. What does that mean to that person? So being alone is one of, the huge warning signs we need to see in older people. Then physical disabilities, and then also chronic conditions. And we will want to just mention, we'll just start a conversation a bit about euthanasia and assisted suicide, to see the legal issues and the ethical issues. But these are some of the things. So chronic conditions, for those who are in hospice care, for 6 months less for you to live, all of those things are warning signs that this person is likely to think about killing themselves or taking their own lives.
Thank you so much. You want to add something? Yeah.
So the warning signs, sometimes it's just what they say. When we started, you gave an example of...
my own grandmother.
Yes. So I remember when I started the program, my dad called me one day and it's like, so I'm the one doing aging studies now. He has some uncle somewhere, and this man is always talking about death, so I should go and talk to the man for... So a lot of people, after a certain age, that's all they call for. My own grandmother, at the age of like 90, every single day she wakes up and she's upset that she's not dead. So you wonder what thoughts, what ideas are in them. I'm bound to think that maybe when we talk about those they're very old, maybe suicide is a peculiar situation for them. This is open to discussion, honestly, because if somebody is 90 plus and then the person gives you all the logical reasons why they shouldn't be here, it may sound reasonable, but it's still suicide. That's not what we want. So just the things that they say, they wanting to die, is a first sign for you to know that, okay, this person would want to go. And if they get a chance, they may harm themselves. And this could also make us start wondering whether some kinds of falls and some kinds of injuries that older persons sustain, it should make us wonder whether they are deliberate or they are just by accident.
In fact, I have a bias here. Dr. Chukwoji, are you there?
Yes, I am.
Yes. Well, I'm a community psychologist, and so for me, my interest always have been community resources, all right, that we can deploy to help, the aged, as far as suicide prevention is concerned. Can we have some community resources that can help, address the issues of the aged and also prevent suicide in the population? At least from your perspective in Nigeria, are there any of such resources around?
Yes, I'm happy you mentioned it. Incidentally, that is one area of increasing interest to me as an individual in suicide prevention. We have this African culture, African ethos of communal living and of interpersonal relationship that we value much. So, and for the older adults, they are also highly regarded and acknowledged in the communities. So if we talk of places of connections for older adults, their major places of connections are in the community institutions and resources. A key community institution that we must in Africa increasingly tap into is the religious institution. A lot of older adults in Africa become more religious as they age. And not just that they become more religious, they also assume leadership positions in those religious organizations. So if we can have a way of working with religious leaders to help bring suicide preventions into the religious communities, we are going to be achieving a lot. And for me, it's not just about providing these services for the older adults. It is also about making them become involved and become champions of suicide prevention. And one area that I'm going to mention is training them as gatekeepers in suicide prevention. We are helping them, but we're also helping them to help other people. if we begin to train them as gatekeepers in suicide prevention. So in that regard, what as Africans we should work towards doing, and as all of us gathered here, is to begin to initiate conversations around suicide prevention in the various churches or mosques that we go to. Just informal group discussions that they attend the meeting and there is a way to talk about people's well-being. You switch into suicide prevention, and gradually we begin to raise the consciousness about suicide prevention in these religious communities.
Thank you. So we can utilize our communal living and also religion. I mean, I think the issue of religion is very important. As we said, as they are aging, they get more religious, and so we need to also leverage that to help prevent suicide. Can I also hear from you community resources in Ghana, which we can identify, tap into to help the aged?
Okay. I don't think it will be any much different from what's going on in Nigeria, but I would like to emphasize on intergenerational contact. And even before I get to that, so back on religion often gives a sense of purpose. And usually when somebody has a sense of purpose, it's less likely that the person would want to die. So that angle, again, can really be exploited over here. And then talking about intergenerational contacts where older adults are able to commune with younger adults, middle-aged adults, so that they share and exchange ideas, it makes life worth living. So if that angle is pursued, it will probably reduce the rate of suicide or even suicidal ideations among the elderly.
Very well. Thank you so much. Intergenerational contact, wonderful. Yeah.
Yes, and just a bit more on spirituality and spiritual beliefs. When we look at advocacy, let's say, as John was saying, starting the conversation, one of the things we found was witchcraft accusations. So if we are able to start a conversation about your grandma is not a witch, your grandpa is not a wizard who is out there to get you, all of these things that affect older adults can really help or go a long way. And even the whole idea of, suicide being a taboo exercise, it doesn't, as I said earlier, suicide can occur at any age. It's not age dependent. And so when we have these conversations on specific issues that affect older people, that will be able to help.
Thank you so much. I think at this stage, I would have to also come back to you. If there are any questions, something to put down, you want to ask, you want to probe further, I think I will invite that. Our panelists, as they are still here, right? We talked on suicide general prevalence risk in the first session, and then we came to the youth suicide in Africa, and the third has been on suicide among the older persons. In fact, Dr. Akoso Ajimai, is it what is the nomenclature? Is it older or aged? So it's older, right? Very good. We have an expert here. She is an expert in the area. That is why I asked her the question. Clap for her. So let us all say what? The older, right? Aha. All right, so please, any question, any contribution on what has been shared so far since morning? Yes, any question, any contribution, anything at all from all the presentations? All right, say. Let's use just some 5 minutes and then we'll wrap it up.
Thank you. My question is, I've listened to the whole program very well, and now my question is there plans to trickle down to high school level, probably to make a high school psychology as a curriculum? Yeah, because I'm a coordinator for College Board, so for all that I've listened here, I'm going to put it in the form of seminar, where students can get at least a minimum of 1.0 credits for going through such a course. In the case of Ghana, is it possible? Because psychology seems to be only at the university level. But back there, they have high school psychology. So all these things could be infiltrated down there. And we can even make it 4 times. We can make it 4 times within a whole school year for a credit. I came here purposely because I have a student who has gone through his high school program. This is just within the week. Today is Monday, so last week. He has a GPA of 3.5. He's gotten universities back in the States. But because of Trump, he wants to stay in Ghana. And GTech is saying his course, because it's an issue, it's a big issue now. This guy has run out of house. His parents today is reporting to Ghana police to find a way to get his son back.
So the question is,
can we get these programs, this high school, this psychology thing down, probably as a core program? So everybody going through a Ghanaian education should be able to take a bit of high school psychology.
It's a very important question. Until I came to Legon and I was giving psychology, I didn't know psychology. So I think we need to tackle this question. Maybe let's take another question and then we answer them together. All right.
Yes, thank you very much. And I am in, my name is Marian Opoku-Ejakwa. I'm with the Center for Aging Studies, first year. We have now started. He said he didn't finish his question. Okay, as a follow-up, I think that before we even get to putting it into their curricula, is to go out to schools and educate them. And it can actually start with university students, it being part of their practicum or something. I'll tell you what, maybe 3 weeks ago, I coordinated an outreach to about 12 schools, 6 in Accra and 6 in Kumasi. And what we went to talk about was mental health matters. And you will be shocked about some of the discoveries that we made. And even the impact it had on the kids and even on the teachers who listened. So I think that it may be faster if we get university students to go out there to these schools and impart knowledge whilst we work through the bureaucracy of putting it into their curricula. Thank you very much.
Prof, a different question or? All right. Prof, let Prof throw a light on this. Yeah, because
Thank you. So the bit about psychologists in senior high schools. Thankfully, we got some a little funding, but with strong support and collaboration from the Ghana Education Service. Prof. Osafo is leading that project. And what is going to happen is that we're going to pilot some psychologists, train them on certain competencies, including suicide prevention, behavioral addiction like gaming, gambling, social media addiction, all of those things, which ways they can help young people and also empower teachers. And so it's a project that is coming on. We are very hopeful of success so that it can be scaled up across all senior high schools in the country. The bit about psychology in the senior high school curriculum had been a long call. I believe in the early 2000s it started. GPA, the Ghana Psychology Council Association, started it. I think they are still on it, even though the momentum has died down a bit, because it has to go through processes. Ghana Psychology Council as well must be part of the efforts. I think it's a good call because we need psychologists in the country. And then the little twist about including psychology into the curriculum, or suicidology rather, I don't know which one, but I think suicide is a multidisciplinary thing, and so maybe the inclusion of psychology will help, where we can bring, issues of suicide into the conversation or discussion in terms of the curriculum content. Now, I want to share a quick experience. So I did my PhD in the University of Leeds in the UK. In the first year, the first few weeks of admission, I had to go through medical examination like we all do when we enter university. And I was shocked that as part of the medical screening, they had to do some bits about my mental health and mental health history, whether I had been to a psychiatrist before, engaged with a therapist or a psychologist, whether I use any substance, alcohol, drugs, whatever, history of depression, anxiety, anything at all, just so they could build a good profile in terms of my health, not just medical health. But we don't do that here, which is a problem. It's a call we have been making. We hope that University of Ghana at least will start and lead the way.
And HR shouldn't be doing the work of psychologists in our organizations.
Thank you. That's a good point. I know Ekwafo Hall started, the Hall Master initiated something like that. So all the new or first-year students who are brought in, before you register for your room allocation, you are made to answer a quick screener of your mental health, and it gave him and his team some sense of where to direct people. For example, there were some students who had fear of height issues, so they were not taken to the annexes. They were brought to the traditional hall building itself. And so things like that to help how we do things, because we have a history as a university where, you know, few cases where students have died by suicide through height and so on. So, yeah, I think it's a call. We all have some role to play. And thank you for those comments. They are useful.
All right. Let me take 3 more, and then we end it.
Dr.
3 more.
I just have a quick comment to Marian's. So I know that the Ghana Psychological Association, they do this outreaches to school on suicide, mental health issues. And for the record, our batch of MPhil Clinical Psychology, that was one of the things we were doing. We were called the Mental Health Initiative. We were in St. Mary's, we were in Abri Girls, we were in other schools talking about suicide. So I think we just, of course, funding is always a major hurdle for us, but we need to keep this up and going out. Yes.
Yes, so thank you very much for all the conversations that has gone on here. I'm here representing the Mental Health Authority, so I work with Prof. Osafo and other things. So it's a privilege to be here to listen to all the rich conversations. So just some few comments. So about the community resources. So there are some that can protect the elderly, or the elderly. Realize that we have some cultural practices where when somebody passes on, the family, come around to, be with the person for some time. Some of these cultural practices are very protective, but it looks like because of modernization, we are spoiling, or we are watering it down. We need to probably enforce some of these things, where people come around to give some kind of support. Then on the second issue that he spoke about, so for instance, I'm a mental health nurse. At the point when I wanted to come and do my first degree, I wanted to do nursing first degree, but then it wasn't so, it was very competitive, so I had to do psychology. I did psychology and I went back to my workplace. My workplace told me that psychology was not relevant. I was like, are you serious? And that's what now it has made me to even understand mental health issues better. But the people who we had there was like, they didn't want me to do psychology, so it wasn't relevant. I was like, do you know the content of what I was here? Dr. Adote Anum taught me, and I was not. Do you know what we went through? Professor Dankwa Dems were here. So it means you lack something. That's been a challenge. That when you're able to, as a mental health nurse, what do we do? It's not about talk therapy. The medication is just part of the work. So these are some of the issues, and I'm also talking about. One thing that, Prof, I've been thinking about, and you also alluded to that fact. So more men die by suicide as compared to women. But depression, which is the main reason why people die by suicide, is twice in women than in men. So how come more men? Because we should expect that once depression is twice more in women, they should die more. Is it that we also have depression and we are using drugs, and because we know drug use is more in men, So in fact, when I was here, that was what instigated my research. So I said depression among drug users, men, drug users between men and women, But the conclusion, but I'm still just thinking about my down research, and for the past few days, for this morning, I was on a TV doing campaign, talking about mental health, drug issues and stuff. And this issue also, I told them that this is the fact. More men die by suicide. So, one of the things we need to investigate more. How come depression is more in men? Men are becoming an endangered species now. If it's true that there's close relationship between poverty, mental illness, suicide, and all the demographic, the social determinants of health, men are leading it, then it means we need to do more for men. It looks like we've neglected men. You know, when you talk about vulnerability, we don't list men as part of the vulnerability list. So these are my concerns. Thank you very much.
We are taking the last two, but on the issue of men, I think that I will ask Prof to do another session like this, and I will not be a moderator. I will be a panel member. Then I will explain. Prof, so I'll be waiting for you. Eh?
Thank you. I'm E.N. Godo with Aging Studies. Yeah, our sister Prinsila in her submission said something that one of the factors the elderly male face, which lead them to commit suicide, is erectile dysfunction. And I see it to be one of the greatest things we need to consider. You see, most of the men face these challenges when they are old. I heard of a story whereby somebody had to commit suicide because he was no more. Died. Sorry. Yes, exactly. And actually, it was due to this erectile dysfunction. So we laugh over it, but still that problem exists, which psychologists have to think of how, at least, to reach them. Thank you very much.
Thank you so much. Nana is here. Nana, let's hear you.
Doc, thank you, Doc. So, one of the things I didn't hear much suggestion going into is, yes, we have decriminalized it, but culturally, what have we done? What do we intend doing in that field? Like you mentioned, inherent in many African cultures is the fact that suicide is an amodin, it's a taboo. You don't even mention it because it is unheard of. To think that a member of your family died by that. And so it becomes a stigma on that family that nobody will even like to associate with that family. To the extent that when somebody from that family is lucky to be scouting somebody where potential suitor somewhere, they will say that, no, don't go here. Because these people, they are noted for suicide. And that is a major dent. So yes, it's good that we have decriminalized that on the books. Yes, very attractive. But can we also look at taking advocacy beyond it to the cultural context where we can address the cultural issues that spike suicide? Thank you.
Thank you so much. On the issue of advocacy, I think Nana is doing so well in that area because he's in the media. And I remember once he led an advocacy against some things going on in the country, and in fact, it really was successful. So Nana, maybe you can start for us, right? Aha. So keep doing it for us. This is Nana Yaokesi of Peace FM. Yes, Peace FM. So Nana, we are going to be supporting that advocacy. Start for us.
Okay, thank you. So I just wanted to add to the issue of, I think Prof mentioned about he going through an assessment, psychological assessment. In fact, I know that University of Ghana, where you go on our STS, we have psychosocial assessment checklist, but just like the medical exam, it's not been compulsory. So people don't do it. And I have an experience with it because when I was at the Careers and Counseling Center as an intern, we did the assessment and we pulled out the data. We reached out to these people and attended to their mental health needs. But I think that we have something like that there, except that it's not been made compulsory. So rather, they stress on the medical examination and not the psychosocial. So if you go on your STS, everyone can check, it's there. It's true. But it's not compulsory for anybody. And I think that it should be made compulsory. It was only compulsory during the COVID era, because they felt like students were going through a lot. And also on the issue of the high school psychology thing, I think that we need much more planning, because I did my thesis and my concentration was on senior high school counselors, their challenges and the resources that were available. And what I found was was a bit surprising, because how can a whole school of about 1,500 students have just one counselor, and the counselor doubles up as a teacher? And the number of hours that the counselor has to teach are a lot. So there was overload. So they concentrated so much on the teaching that they neglected other aspects. And one person that I spoke to told me that even GES would rate you on your teaching before the counseling aspect. So I think that it has to do with misplaced priorities. I don't think that the mental health of these students are the priorities of the education sector. Thank you.
Thank you so much. Thank you so much. All too soon, our time has come to an end. In fact, the program has come to an end. And so, Prof want to say the last word, right?
Yes. Good. Thank you very much. So, on the bit about the UG psychosocial screening, I remember before it was rolled out, some of us were given the opportunity, I think Johnny and I and another colleague, to review it. Even though it is labeled psychosocial, you go in there and the issues are purely psychiatric. The social bits were missing, and the general mental health issues, psychological issues were missing. More psychiatric. I believe that we can do better. And of course, we are still available to provide support. On the bit about the elderly suicide, maybe I came in a little late because I had to step out to attend to a few things. So I know also that elder abuse, which is quite popular in our context, is another factor that elevates suicidal tendencies on the part of our elderly. On the bit about intergenerational engagement or interaction, I think on our side, in this part of the world, we've not been too lucky, because none of the social media giants, I mean the tech companies, is located here on our continent. And so sometimes when you're talking about the elderly, they don't fully appreciate what is happening and how our context, will require some things to be included. At the moment, there's a huge pressure coming on them. In fact, WHO has launched a document, a resource for how we can engage the elderly in the development of AI and social media contents and tools. But they are, as usual, because of the profit motive, they are dragging their feet to fully give, if you like, activation to the recommendations in that resource. And so I think we need to do more, because, look, you go onto social media today or any of the AI tools coming up, and you could see clearly that the target is young people. The elderly have been completely cut off. But if we can use social media and AI to fully engage the elderly as well. Thank you very much.
Thank you, thank you, thank you. I think that it has been an enlightening section, very illuminating. We learned a lot from the earlier panel discussion we had on suicide in Africa, prevalence, to youth suicide, to suicide in the older persons. I think that a lot has been said. The conversation has started. Let's keep on, having such interactions, such sessions. And thankfully, we have our brother here who is also in the media. There's a lot he has already been doing. So I believe that we can also get the media along in all this. Because the elderly, because they are in the homes, they are glued to the television, they are glued to the radio. And so some of these interventions through the media can also go a long way to help. On this note, I would like to hand over the microphone to the director to give us the closing remarks. Director, we want to go for lunch, so do it quick for us.
Shall I put the hands together for MC? A moderator. Moderator, papa. All right. Moderator, papa. Well, ladies and gentlemen, all too soon, we have come to the end of the program. And I like us to also put our hands together for our audience online. And then the presenters who presented from Cameroon, Nigeria, Don Bosco, Titilae, and Alain. These are friends we've been working with for the past 3 years on suicide prevention in the sub-region. And I think that if we put our hands together for them, that would be wonderful. We also want to say a big thank you to our brother, Professor Kofi Boakye, and the University of Leicester. It's something we have started. And one of the areas that we are interested in exploring further is the intersection between aging and suicide. And also quite even interested in, for example, doing a longitudinal. I was just telling somebody, how will it look like if somebody turns 60 years and then you have begun rolling a study on the person from age 60 to about age 65? That you can get, for example, data every year, see the changes that take place as the person ages, or as the person ages, and then as the person grows. So Akusia doesn't hold my neck. As the person grows, what are the changes that take place, for example. So we'll be looking forward for that. And I'm glad that Dr. Johnny Andwata, the moderator, was even saying that we should be thinking of doing 1-2 on, for example, men and suicide, particularly looking at the issue of erectile dysfunction and dysfunction. It's a big issue. It's a very, very big issue. So that is on the table. We are also very much interested, for example, in some other subsequent seminars we'll be organizing. We'll be looking at nuancing this way. For example, data from the criminal justice system, for instance. How about those in the prisons? What is happening to them? Professor Boakye mentioned, for example, a data that we're currently working on, those on death row. What is happening to them? If you look at their mental health, they say they will kill you, but they haven't killed you. They say you are going to die, and you have not been killed yet. What is happening to you? And even those who are not on death row, what is happening to them? These are things we are beginning to think through and see the way forward. But I think that eventually we have to think about intervention. And like Professor Kwashi indicated, that's one of the areas we have taken up this time around as the Ghana Association for Suicide Prevention. We want to now look at potential intervention models. One of them is what he mentioned as a response to our brother's question. How do you intervene? How do you make our schools safe spaces, safe places where teachers and students, can relate, can study, can work, places where people who are experiencing mental health crisis can easily get help. So that is coming up, is in the pipeline. And of course, the media. It's a big tool, either a tool for something good and a tool for something bad. So that is also something we're working on. And so, ladies and gentlemen, the story should continue. The narrative should continue. What is the narrative? That suicide is preventable. And again, that if there is anything you should take away from this particular seminar, number one is that suicide is preventable. Number two is that you are the agent. You do not need any specialized training to learn how to give hope to somebody who is suicidal. So all of us should become agents who can be very helpful when it comes to suicide prevention. Again, let me remind you, this is the Center for Aging Studies. This is one of our seminar rooms. You can follow us on all the social media handles, TikTok, Facebook, YouTube, where we are transmitting live on YouTube. Live on YouTube, so you can go there and watch and share the link with your friends. So just Google Center for Aging Studies, CFAS, and then click the button, and then you are live there. All right. So on that note, thank you very much. We have lunch for you, so don't be in a rush to step out. They will sort you out and make you feel good. Those online, we are serving your lunch online for you. Okay, so all the best. All right, so ladies and gentlemen, thank you very much for today, and we'll see you. God bless all of us. Bye-bye. Let me pay attention and tribute to my technical team. Shall we put our hands together for the technical team? You know, I brought them from my church. They are just incredible. Prempe is the lead. And then David is a French guy. David, you should have spoken French for us to hear you. And then my own, Charles Osafo, who is there. Yeah. They've done well. Charles? Fraternize.